25.
Hello.
Okay.
Hello.
Okay.
কখন লাইভে যাবে একটু জানায়েন। ওকে 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 ওকে।
তুমি ল্যাপটপটা এমনি ওইখানে রাখলে দেখো না ইন্টারাকশন হয় কিনা। হ্যাঁ শুরু। Mute. Yeah. Okay. Speaker will be off. Yeah. Okay.
মিউট থাকবে, কোনো সাউন্ড অফ থাকবে। হ্যাঁ,
Speaker off. Like there.
লাইট কম।
Okay.
আসলে আমাদের এই জায়গায় ফোকাস করতে হবে।
Hotspot. Use your hotspot. Use your hotspot.
আচ্ছা থাক, এটা ইকোটিক হতে পারে, বাদ দিন।
বাসা যাইতে পথে সময় লাগবে না। হ্যালো।
Yeah. Jamal bhai,
Do you hear me?
Yeah, of course.
Yeah. We are in
you have a very crystal clear voice. Yeah.
We are in a different program. Health secretary came just. He went and then I have seated with the mobile.
Okay. So it's better with the health secretary. You can do an angiogram of health secretary.
He has seen. He went to our new cath lab and he has seen how to do angiogram, how to do angioplasty.
I want to do his angiogram.
Just now left.
Okay.
কি খেলে বাসা যাবে দেখো।
Jamal bhai, we are in the middle of the case.
Hello.
Yeah. So we don't want to keep the wire in the patient's artery for a long time. So please start it.
Yes, it's just 3. Our session is also from 3.
Okay.
Thank you. It's my pleasure that you have progressed. Then can you show us the angiographic view?
You are in live now?
Yes.
You are live?
Yes, I am in live. I am in live with you.
Oh, only live
as a moderator.
Okay, but you don't want to start officially now, right?
Okay. As because time is time.
Yeah. Okay.
Interpretation ready.
Assalamualaikum Jamal bhai. Assalamualaikum Misbah.
Yes, welcome sir. So it's a very after a long time. So welcome sir. Thank you.
Thank you, Dr. Mesbah.
Professor
We are grateful to you as because in the last year you have also arranged the live case in Radial Live in Bangladesh from China.
Pleasure,
and this year also in virtual case you are participating, and your boss, Dr. Wu.
Professor Wu already joined. The professor Wu already joined, so maybe you can talk with Professor Wu.
Okay.
Hello, Dr. Wu. Hello, Dr. Wu. Hello.
Juren, ni kan kamma?
That he has entered into the session.
Yes, sir.
And Dr. Wu,
Welcome, Professor Wu.
Professor.
Maybe his voice maybe not very clear.
Okay.
You can continue,
then,
sir.
Then, Mesbah, we can continue the session as
Yes, sir.
because.
Yes, sir. Please, sir. Please.
Okay, thank you. And Dr. Dr. Sadur Rahman.
Yeah.
Uh,
Yeah, I'm here. I'm here live and live.
yes. As a chairperson, Professor Nazir Ahmed and Professor Badiuজ্জামান from National Art Foundation and Dr. Wu, Professor Wu. Professor Badiuজ্জামান, are you with us? Professor Nazir Ahmed from National Heart Foundation, my great professor from Sherebangla Medical College, my origin. Professor Nazir Ahmed, probably they have not yet entered. Okay, then Dr. Mesbah, we can, this case has been already been started and we can talk with the cath lab. And he is one of the renowned international cardiologists of the country from Ibrahim Cardiac Center, and his choice is slender PCI, small vessel diseases, and he has many calcified lesions. He has many necks in different difficult topics. Let us see what he shows today.
Okay. Thank you, Professor Mirjamal. And first, I want to introduce my team. I have with me, our assistant professor, Dr. Saini, and Dr. Aisha, and also my cath lab team is here. First, I introduce. Can you hear me? Can you hear me, Professor Mirjamal?
Yes, sir, we can.
Okay. So let's first see the case report. So I'm asking Dr. Aisha to present the case.
Thank you, Sadhu sir. Can we have the slides, please? So our case was a 64-year-old female, was diabetic and hypertensive with a history of hypothyroidism. She presented to us this time with CCS class 3-4 post-MI angina, which had worsened over the last 6 weeks. This was on a background of prior MI anterior, where she had presented late in June 2020 and was managed conservatively then. ECG showed a prior MI anterior this time also, and her ejection fraction was 40 to 45%. Coronary angiography done showed severe diffusely calcified triple vessel disease with a syntax score of 29.5. Heart team approach was undertaken and CABG was deferred considering diffuse calcification.
Okay, that was our case. Let's see the angiogram. Everybody is hearing and seeing the panel.
Hello.
Professor Mir Jamal. Hello.
Sir, kindly unmute yourself, please.
I am I'm
Yes,
not
yes.
muted. Yeah.
Uh,
So you're
I,
hearing. So let's see the case now.
I am seeing the.
Okay. Let's see the angiogram first.
Yes, show us.
Okay. So start with the angiogram. So before angiogram, this is the disastrous thing is that you see you can just appreciate the huge subclavian loop, which is sometimes
Yes,
common among the elderly patients in our country, especially female, like their like.
Whether the angiogram was done previously or today.
No. Previously the angiogram
Oh,
was done
then
today
the,
is also today again the angiogram has been we have relooked the CAG. Show me the CAG. So this is RCA.
yes.
You can estimate that even angiographically you can see moderate to severe calcification is there. And in the distal RCA, you have seen that there is 80% stenosis. And especially the left system, can you go for the left system? If you see the calcification, can you see
তোমার
even
ল্যাপটপে দিয়ে দেবেন
angiographical?
কেমন দিয়ে দাও দিয়ে দাও, ধরতে পারতেছে না।
Angiographically, you can see the calcification even. So run it again. So you see the calcification, and also almost totally occluded LAD in the mid part. And it's a and calcification has been extended from its proximal part, starting from the left main up to the distal part, and that's why our respected head of the cardiac surgery has showed me his back that he is not going to operate it.
Next, please.
Next slide, please. So you have seen that LCX has got which is a small calibered vessel, but it has also a 90% stenosis in proximally. But OM branches has moderate disease, but with TB3 flow. So if you show me the calcification again, and geographically you can see the calcification. You see the calcification. Can you see?
Yes, we are seeing
Can you see
calcification.
the huge calcification? This is
Yes, yes,
angiographically when you can see this sort of calcification starting from the left main means it is
yes.
severely calcified. Angiographically even. So what we have done, because patient was screaming with angina, because on and off angina was there for the last 2 days, she was in our under our observation, and whenever she had angina, she goes into LVF,
হ্যাঁ, ওটা
evolving
সেট
LVF,
করে দিয়ে দাও তাহলে।
and
বাথরুমে ধরতে পারো, হলে রাখতে পারো।
that's why just after puncturing the right radial artery and after engaging the catheter, I couldn't waste my time to start with. Okay, because
Yes.
I was not pretty sure that whether can you show me the angiographically the LED again? You can appreciate that these stenosis just after the
আচ্ছা।
septal perforating branch. You can see. Is it? After the septal perforating branch, you can see that there is a very, very thin line like the encroached river of Turak. You see that because it has become a small canal, not a river at all. So you see that to wear these things through this calcified territory around, it was my challenge, and especially that the carved part distally. Can you see that? If you make it magnification.
আমাদের ওখানে হয়, হয়, আমাদের ওখানে হয়।
So you see
হ্যাঁ,
here,
করে করে।
after the septal
Yes,
perforating branch, there is
yes,
nothing
yes.
almost. The channel is
Almost
almost
nothing. Yes,
obliterated. Almost
yes.
obliterated. So it was like a CT or something because it is thin, that the tortuous and serpentine line
Yes.
which is connecting it towards the distal LAD. And it's encroached by the severe calcification.
And
So I
vessel
was,
diameter is also minimum,
yeah, it's very, very, very small. What you see.
2.25 maximum or 2.
No, what we have done then, now let's go. Already we
You
have
have
done what? Yeah,
dilated.
we have taken, no, we have taken the XV is 6 French guide catheter 3.5, and then
Yes,
we have taken the micro catheter along with the Fielder X3. That
yes.
Fielder X3 wire, but Fielder X3 wire was not crossing. You go next. You see that after the macrocatheter, field direction is always going towards a very small septal branch. So later on, I have done the knuckling technique. Yeah.
Ah,
So after
yes.
knuckling, the wire has gone. So the initial hurdle has been crossed. So far, I was a little bit happier that it didn't go to a very false track or in a subintimal space so far. So later on, next, we have exchanged the wire with a shown blue guide wire.
Yes.
See, this is our workhorse wire.
Your micro catheter was entered up to the tip of the vessel.
Yep. That is
Very good.
fortunately,
Very good.
fortunately it has
Yes,
happened.
yes. That is
Fortunately
your
it has happened.
good luck.
And
Yes.
yeah, then later on I have exchanged it with a shown blue, And after that, I just my associates here was telling that let's do the IVAS first. I told that without ballooning, I can't do the IVAS because IVAS catheter maybe will be stuck there, and the catheter will be damaged a little bit. So I have done the ballooning with a smaller 2x10 NC balloon. Go for NC balloons. So the balloon was crossed, but with a very hard effort I have to give to cross the balloon through that stenotic part. So after that ballooning, next I have ballooned the whole steno segment, and fortunately it has been ballooned well without any dog boning effect. That means the calcium is very deep. Later on, after ballooning, we have taken the IVUS, and let's see the IVUS picture. So can you see the IVUS now? So it has started from the distal part, and you will see that in and around 360-degree calcification, and somewhere it was like 270. And after 210 ballooning, in some places the calcium has been a little bit cracked, and that's why it was. I'm fortunate that with that ballooning it has been cracked, because my rotamation is already here. So whether we can go for a rota or not, but the ballooning has cracked the calcium a little bit. And you see that the vessel dimension, proximally, if you go, because I have the whole length, I have done the IVUS, and you see that this 360-degree calcification, and somewhere it was deep calcification was there proximally, where the stenosis is not that much. And even angiographically, you can see that the proximal, the deep calcification is pretty obvious there. So after IVUS, so you have seen the IVUS, right?
Do you have any comment regarding IVAS, please?
You have seen the IVUS, Professor Mir Jamal, and
Yes,
Dr. Yu?
the divers.
Yeah. Okay. So
Yes, yes.
yeah. Okay. Then what I have done, I have been encouraged enough to take a 2.5 12 NC balloon Eupora again to pre-dilate it more to prepare the vessel. Go forward. Okay. Next. So, so we have pre-dilated it again by the 2.5. We have upsized the balloon.
Upsize the
NC
balloon.
balloon. Yeah,
And what is
NC
the
balloon 2.5.
which balloon?
It's
Which
a
balloon,
it's a
Professor
it's a
Sadhuraman?
it's a
NC
2.5 12 Euphora.
Euphora. NC Euphora.
Yeah. Yeah, Euphora has got, somebody tells that it has got a uniform capacity to and a sustainable capacity to predilate.
Yes.
Somebody says, yeah. So that's why you have tried that one. And then later on, after next one, then what we have done, then the question to you and also the respected panelists and
Analyst.
chairpersons there, that here whether I will go for rotablation or I will try for the stenting.
Uh, our panel of experts and chairperson Dr. Wu. Hello. Professor Wu, are you with us?
Moment. Hello. So I'm Dr. Wu.
Yeah.
So
Yeah, Dr.
I'm
Yu.
sorry
Thank
because now on the way to the rail station, so it's noisy a little bit. But
Okay.
I find so this the case is very tough case. So it's
Yep.
very long calcified lesion.
Yeah.
And another problem is the radial approach is very torturous. So I
Yeah.
wonder. So the first of all, so we should have the very big, strong the guiding caster. So the strong backup,
Yeah.
the guiding caster,
I have.
and maybe we also should prepare the rotation and Godzilla caster.
Okay.
But I find that so the balloon is easy. So the catch population is it's not very difficult to be opened.
Okay. So it's better. I have taken. So you see that after that, I have taken a body wearing here. Let's say that. So I have taken another wear, so that I can put. I can try for a stand to cross. If I can put the target lesion, then I don't want to go for too much manipulation of calcium proximally.
I recently.
May I try it? Give the 2.538.
So I think the diagonal is very big. So the diagonal should be the
IVAS picture is telling distal reference diameter is 2.5. Distal reference diameter is 2.5, and I'm taking a 2.538 stand. Let's see whether it will cross through that proximal calcified lesion. If it's not, then I will have another plan to do. Let's see it.
I'm requesting panelists to give their comments, please.
Flush.
Professor Ghulam Azam has joined.
Okay.
Professor Ghulam Azam.
So we are trying to negotiate a 2.5
Professor Ghulam Azam, are you hearing me?
resolute on extent.
Unmute you, Ghulam Azam. Professor Azam.
Oh, Professor Jamal, it's the stand has crossed. So it's a big.
Yes.
Yeah,
Which stand this one?
It's a Onyx 2.538.
Onyx.
Yeah.
Yes.
Okay. So I think in the proper
2.5.
position we have. Yep.
2.538 millimeter.
Up.
Up, please.
I have a body wear
Hope for
here.
the best
Yeah,
for
I have a body
inflation.
wear. Yeah, I have a body wear, and it's in
Oh,
uniform. Yeah, it is
hopefully it
uniformly
has
inflated.
inflated well.
Yeah, uniformly inflated. Okay, down.
One thing against rota super, I assume that as because there is fissuring or cracking of the calcium, so it can be done without rota.
Yeah, and the other thing is that your calcification is started from the left main. So whenever I
Yes.
will cross the bar, the proximal LAD has severe calcification. So possibly the bar will have got some conflict with the proximal calcification also, and I'll be bound to put a stand proximally also. So you know that even that will be a mess. That will be a mess. So here body wearing is very much helpful, especially for tortuous and calcified lesions, to take to just deploy a stent or to just deliver a stent there in the tortuous course. So let's see the scene A. Okay,
Imran,
it's not bad. It's not bad at all. Okay, give me another balloon. Do you want a IVUS now?
Yes, we want to do IVAS now.
So I am putting IVUS again to see whether the apposition was there or there is some dog boning effect inside angiographical in IVUS image.
IVAS, please.
in the mid part, there may be some under expansion
Yeah,
of the.
I'm taking the IVUS again.
So I think Professor Mir Jamal sir, preparation of this
Sure.
bed is very important for calcified vessel.
Yes.
Do you have any option or any other thought about this preparation?
We are hearing you, but it's slow. You can raise the voice, then we can understand more.
Okay, sir. My question to the panelists: whether do you have any different thought about preparing the bed in this case? we have titrating or upsizing the NC balloons for preparation of the bed. Do you have any different thoughts? So this is the post-stenting IVAS.
So you
Yes.
see in the mid part of the stent, there is some malapposition is there, and
Yes, yes.
also
In angiographically,
proximally,
it was also said.
yeah, but also proximally, the stent is not well apposed. So I need a 2.75 NC balloon to
Yes.
just to oppose for well
Okay.
apposition of the stent. Okay, so let's see. Thank you.
Yes.
Here I'm putting out and 2.75 euphora NC
NC
12
2.75 euphora
12
into 12. 2.75 12 NC.
Okay, give me the balloon and GTN. Twelve. Okay.
You can show us the IVAS, please.
You can see the IVAS here again
IVAS run, please.
by this time. After
So Professor Saidur Rahman sir is now negotiating a
a bit louder
2.75
voice.
into
Yeah.
12 NC balloon for post dilation of the stent.
Is there anybody there, or everybody's just? Where is Dr. Azam? Okay.
Yes, now I in the
After-
session, but on the
After
way
finishing,
and lift,
after finishing
I
all
will
this,
be available within
we'll
5
go for
minutes.
16.
Okay, sir, Professor M.J. Ajam sir.
Down.
I am Shahin.
Professor Azam, are you eating?
Sir, just 5 minutes, I will be free, sir.
Oh no, by
Azam
that time-
probably hungry, yes, because just now.
No, still hungry, but I just stepped
Okay,
down
down.
from my car. Then now I'm going to leave.
You left, and I am sitting inside the
Sir,
hospital.
you just continue, sir. 5 to 10 minutes, then I will be there. Sir, please, sir, you continue, sir.
Okay.
Okay, sir.
So post dilatation is ongoing with 2.75 into 12 millimeter NC balloon.
It is also euphora.
Yeah.
Yes, euphora.
Said earlier,
So IVAS,
Dr.
No,
Professor
sorry.
Said Alia Sultana has joined with us.
Yeah, he is my classmate in Dhaka Medical College.
Oh, very good. She is one of the renowned internationalists.
মিশুর কাজ আমি I just came back from my office sir.
Yes.
মিশুর
Yeah, Alia. So you see, after post dilation with the 2.75 NC balloon, I think in this tortuous calcified LED, the position is reasonable, isn't it?
We are not hearing.
Can you hear me now?
Yes.
Yeah, I think the position is after 2.75
now
12 NC. I think in this tortuous calcified lesion, so far what we have seen in the angiographically, but the IVAS is telling that the malapposed part we have opposed by 2.75 NC balloon. So you need another
Yes.
IVAS again, or I don't like it because after
I do
stenting,
not think another IVAS.
yeah, because it's almost I think I have done the job without rota, and
Yes.
that I wanted desperately before starting the case. I didn't want to, so I am leaving the I am just taking the final pick.
Rota.
Sorry,
Are you doing rota once again?
no.
Sorry. IVAS once again.
No.
This
No.
was the previous one.
Yeah, that was the
Okay,
previous one.
Okay.
Previous one means after stenting. After stenting, I have done the rota, and then I have done the
Show us
pre-post
the
dilatation by
angiogram, final
2.7
angiogram.
And now I'm going for the final angiogram. Okay, here for left system, because I have also right system there
Yes. Okay.
to handle. So I'm pulling out the
So
wire, and let's
sure.
see. So you see good blushing is there. There is no slow flow or no reflow is there. The proximally, you appreciate that there are some at the level of the diagonal branch. There are some diffuse stenosis in the starting from the proximal part.
Another view.
I'm taking the yellow caudal because which always I take to see the left main. So I think it's okay here. Give me the right catheter.
Yes.
Are you happy with this one?
For RCA.
Are you happy with this picture? You could show me the
Uh,
before the back one.
Previous.
This one, the previous one.
Looks good, but
Yeah.
proximally it
Proximally,
seems to
this
be.
relation, yeah, this relation was there, but you see that starting from the ostial part of the LED, there is some diffuse
Yes,
calcification is
yes,
there, and after stanting, because this stent is, you know, that it has become
actor.
2.5, so the stenosis has it seems more now proximally, because already I have over dilated it.
Yes.
But Dimitri flow is there. I don't want to put a stent in this calcified scenario up to the left main. You want it.
Dr. Wu, what is your comment regarding this? Professor Wu? Professor Wu, do you hear me?
It's section here.
Angiotracheal.
Dr. Mohammad Shafiqur Rahman, Dr. Shafiqur Rahman Patwari.
The proximal part of the
There.
LED, there is some significant lesion.
Have you seen the angiogram previously?
Yes,
I will show you the angiogram first initially, the initial angiography. So show me the LED. You see, it was there like that. It was there, and in IVUS, the stenosis is not that much. It is the IVUS. I have seen I have seen the IVUS also there, and IVUS is showing the deep calcification in and around.
Angiogram.
Okay. Is there any question
Show us the right
or
coronary
comment
artery.
there?
So I think the
Sorry.
I'm Dr. Wu. So
Yeah.
I find so the lesion in the RAD, it's the result is good. It's very good, very good result. And do you want to move to the right side?
Yeah, I'm going to move to the. I'm going now to the right side, because that one is actually will give much more comfort to the patient, because already the patient has ejection fraction reduced to 40%, and the anterior territory has less viability rather than the RCA. So
Yeah,
RCA territory.
the
So
right
I have,
side is also the very tortuous. So it's also
yeah.
the
That
tongue.
one is also a challenge. Whether I need a
Yeah,
rota there,
right.
maybe. Yeah, let's see.
So which kind of
I'm going
guiding
to take. I better to take a Ikari right.
Ikari right.
Yeah.
Okay.
I'm going to take a Ikari right here, because they have given me forgottenly the RCA catheter. 6 French or 5 French. You can no 6 French.
So please give us 6 French Ikari, right? Right coronary artery is very much tortuous. You can see with calcification.
I should say good morning. Green, blank.
Yeah. Where, please? RC run করান.
So you see, this is also another challenge here. Where?
Where, please?
So I'm taking a simple Sheon blue or workhorse wire to cross it. Let's see whether it's going to cross.
There are many challenges in this case on the right RCA. One is the tortuosity, another is calcification.
Yeah. You know, Professor Mir Jamal, the problem is here that whatever the bifurcation, whatever the lesions in like CTO, even whatever it is, you know that the calcified lesions are so helpless things for an interventionist, because whatever you are estimating, you don't know that whether it will cross. That's a big problem. Whatever the modalities you will take, sometimes it may not cross. That's the problem. That's such a helpless situation. So sometimes I feel that I will go inside and I will crack all these things by myself. Test. So it's crossed. It's crossed.
Good.
The wire has been crossed. Well.
Sheon below.
Yep.
What is the wire shown below?
Yeah, wire shown below. It's our workhorse wire.
Balloon, please.
Oh, very good.
210. Or 2.515 NC.
2.5.
Dr. Abul Khair. Dr. Abul Khair.
2.5
Are you with
before
us?
Please give it.
Shaila Nabi. Dr. Shaila Nabi.
Assalamu alaikum, sir.
Make your comment or proposal regarding the management of right side. Yes, already across the wire.
You see the vessel is very much tortuous with
Very
severe
much
calcification there.
And also calcified, sir.
Yes, heavily calcified. Heavily calcified. Yes, balloon is crossing. Oh, guide is going out.
Yeah.
Crossed. Good.
Yep. Okay.
Okay. Up, please.
14. Okay. It was slipping. The balloon is slipping, so the calcification is there. Down.
Dr. Nupur Kaur, are you with us? Dr. Nupur Kaur.
Which balloon you use here?
Here the NC balloon 2.5, 12, Euphora.
Again Euphora.
that old one I have taken.
Okay.
The
old one crossed. Very good.
Yeah, I have just wanted to just make a bait with the calcification there, that whether you will cross or not with the old one. Up, down. Up, down. So do you like me to stand the proximal part also?
After pre-dilatation,
the proximal
we want
RCA,
to see.
The proximal RCA, not the distal RCA.
Proximal RCA.
It's the accordion. It's an accordion effect here.
It will require.
Yeah.
It
So
will
it's
require.
better to. Yeah, but distally the lesion has got some.
Better I also want to pre-dilate it.
Right side, right side.
Proximal also should be pre-dilated. Today's calcium behaves friendly with consultant.
Yeah. This is that sometimes the life cases are,
Yes,
sometimes it is good, sometimes, but
I
all the
was,
time the radials, the lives what I've made already in different times. Every time that Allah has given me some.
yes, you are fortunate, as because this kind of calcium with heavy
because because
toxicity.
I was really very much worried for the patient, because patient was
Yes,
so symptomatic. Even
Uh,
when I have wired the LED, patient was screaming with angina. I don't want to do the IVUS here again,
yes, no
because I
need.
don't need it. So better to go for stenting.
No,
Yes.
proximal part dilatation.
Proximal, yes. I am also with him in the same opinion that proximal should be dilated. Otherwise, our stent may stuck.
Okay, but that is for the tortuosity. Whatever you are seeing here.
Then before the
Because of the
before wiring,
Yeah.
show us 1 second,
Also
please.
there is some disease. Yeah. Show me
Before
the
wiring,
RC.
what is the situation of that side?
NGO
Yeah,
view of
there was
RCA.
disease. There was
Right
NGO.
disease
corner.
there. Yeah.
Yeah.
There was disease there, no doubt
Oh,
about it, but
not
not
so
that
much.
much.
No, not so
Yeah,
that
that is
much.
due to
Yes,
wiring, because of the
yes,
wiring,
yes,
the
yes.
accordion
They are
sound.
due to wiring. Yes,
Yeah.
yes. Then we can cross
So let's try. For
without
the
dilatation.
yeah. Let's try for the standing. If if it doesn't
Yeah.
cross, then we will
Then we
predilate
will
it again.
dilate.
Yeah. Yeah.
Yes.
Okay.
So
So
what will be the
what
size?
will be the size of the stand here?
We shall have to give from distal
Yeah, after the acute marginal branch.
after the acute marginal branch. Then it will, I think, require 30 plus 34 2 or 38.
Yeah, but if you see the angiogram,
It will
there is
not
a bend
cross.
here. No, there is a bend
So
here.
long, so
No,
long
there is a
stent will
bend
not.
here. Can you see? Show me
Yes,
the angiogram again.
NGO.
yes,
Because
when.
the stenosis target lesion is not beyond that tortuous part. That one is not that much bad. You see that
Fix it.
tortuous part
Mm,
distally in the distal
after
artery.
after the
The
acute marginal branch,
yeah
it is diseased,
yeah.
and there is a, part just proximal to the BLB and PD, looks like dissection or something else.
No, that one is due to maybe wear, because of the
Well,
tortuosity. The wear is
maybe
showing.
what?
Yeah, maybe
Yes.
the wear artifact is there.
Then I shall have to cover so far, I think.
Okay,
But
let's
long
see
stent
again.
will be difficult to negotiate.
Yeah. That's I'm saying.
Very difficult. Very
So
difficult.
and to take another.
Take another scene here.
Professor Wu, what is your decision regarding the stent? Professor Wu? Professor Wu, do you hear us?
2.530.
2.530.
I think 2.530 I'm taking. Let's see.
Okay. If does not cover, then we can give another one.
Yeah.
Good idea.
2.530 stent, please.
I think I
This
need.
one also. This
I
one
think
also, I think.
I need a body wear here.
I think
Maybe.
With the body wear.
it's a 6 fence
Because
catheter,
without body
so
wear, this stand
we
is
have
not
no
going to
problem.
go there.
Not good. Yes.
Yeah.
Yeah. Another wire, please.
Professor Wu, do you hear us?
Yeah, I'm here. So
what is your idea regarding
I'm
the distal
watching the
stent?
procession.
Regarding the distal stent.
So the sector wine to the body wine.
Body wire, yes.
Yeah, I'm taking a
The
body
body
wear
wine
because
to
yeah.
the strong
Thinking
support.
that it may be difficult to negotiate a long stand, and that is why he is giving the body wire.
I think this is a good idea because this the proximal is very torturous, but after the wiring, so the
yeah, there is some accordion sign here.
to make the straight.
Yeah. Uh-huh.
Dr. Mansurul Haq, are you with us? Mansurul Haq.
So do you want to use the iris to check the?
No.
Do you want me to do the IVAS?
Yeah,
I
because
want to
I'm
check.
afraid because the lacing,
Yeah.
the just located in the curve, in the first curve. So I'm afraid. So
If the stand doesn't cross, then I will take the IVAS again, and I will do whole the proximal segment predilatation also.
Yeah. I agree with you.
Yeah. Flush.
So this time the Roman sir is taking 2.5 30 millimeter stent. 2.5 30.
So the guiding tensor is very good. It's long.
Yeah. You see, even the body wear is not going. Yeah, to big deep inspiration. Sometimes you know that deep inspiration helps. In sort of
like subclavian loop, subclavian loop.
Yeah, in case.
Shush. Okay.
So
You
this
see?
is the stent.
Great.
You see?
Great.
That's why you're telling. Yeah. Okay.
What is the stent?
It's a integrity 2.5.
Resolute integrity due to financial.
Yep. Yeah.
Okay.
So I'm going to the caudal view to see the vessel. You see? So it has been covered. I wanted to give it up to the acute marginal branch, not crossing the acute marginal branch.
Yes, yes. Just below the acute marginal branch or at the carina of the with acute marginal branch.
Yeah. That's I have done. Okay. Up.
Yes.
Oh, so how very long stent? So very long.
Down. Okay.
Even well inflated also.
Yep.
Synapse.
So what's the size of the stent?
2.5 30.
30.
Oh yeah.
Okay.
There is some dye stagnation there, so I have to put the catheter out, inflate it, ready, and up. I'm inflating it again. Okay.
Again.
Okay, down.
Oh, no, there are some reasons around it.
Yeah. Because
some
of
reasons. We shall have to post dilate.
Yeah. I'm putting this balloon from here. Patient is screaming with pain because of the stasis of the contrast distally.
Yes. And now you will
I'll
withdraw your.
Yeah, I'll
you
withdraw
will
my
have to
body.
withdraw your body.
Yeah,
Yes.
I will withdraw my body after taking the balloon there, because that body will help me.
You will enter and then.
Yeah.
That's right. Very good.
Yeah.
Very good idea.
Okay.
You see, still there is some slow flow is there.
GT.
Still slow flow. No, the blushing is good. Yeah. Okay. Take me the 2.75 NC balloon.
That
12.
2.75 12 NC balloon.
The ECG
So I
has
think
been,
the wine is already chilled. So second stent should be easy. To be
that's I'm telling. That's I'm telling. The jailed wire will help you to put anything there.
Yes.
Whatever you want.
I think a small balloon 2.75 into
that's I'm telling.
maximum.
That's I'm
12 to 15.
2.75 12. The same balloon I'm taking.
Yes.
Because the proximal stented segment should be inflated.
Yes.
The distal one has been inflated well, but the proximal stented segment is not inflated.
Mid part is also.
Yeah.
So I think we have another 15 minutes.
Yes. You have also another 15 minutes in your hand.
Go for hello, Carol.
So, Mir Jamal sir, do you have any comments regarding the management of this calcium?
Very good comment I have to tell, as because with this type of tortuous as well as heavily calcified vessel without rota, doing the procedure is really a challenging work, and we must have to congratulate the
Okay, up. Thirteen, 14. Okay,
yes.
down. It's inflating well. Okay, up. 16. Down. Up.
So we want to hear something from Professor M.G. Ajum sir.
Okay, he's still eating? Is he still taking lunch? Okay, down.
Probably.
So you see, after ballooning, usually I traverse these things like this, whether there is any strut fracture or any sort of malposition there, the balloon, inflated balloon, will never go like this. So I usually do that one after ballooning, especially the bigger balloons.
So now we have
So
to
I
look
think
about
for this very long, very tortuous lesion, so
Yeah,
the last thing is difficult. It's the stating is difficult because it's very long, very tortuous. But if after stating, so I think it's very, it should be safer for the procedure.
Yeah, you
And,
see, that's
I
it's
think
beautiful.
Yeah, but I think for the long term outcome, so maybe after second stint, so and we should use the iris to
Yes.
check. Yeah.
I also want to see the IVAS at
You want to
least
see the IVAS? Okay, okay,
yes.
I'm taking the IVAS here. Up, up, up.
Okay, IVAS please. Okay.
Why the pressure is low?
Dr. Mesbah. Dr. Mesbah, have you any comment regarding
So
this?
actually, it's a very the comment how to do the complex PCI with the very
Yes.
innovative way. And today I really feel like this procedure without the rotablator, it's like a dream for the young people. And the way he did, it's an excellent job in the tortuous and calcified lesion. So I really congratulate from our side to the professor who is doing the procedure actually, and
Professor
the
Saidul
lesion.
Rahman.
Yeah.
So we are negotiating IVAS catheter.
Yes.
IVAS please.
Okay. So let's show the IVAS.
Yeah. It's running. Pullback is going on.
I think almost well opposed here.
Yes.
Proximal. So it's coming up from the stent.
I think, Dr. It is opposed. You are happy with the IVAS?
Yes, we are happy with the IVAS. Show us the part just distal to the tip of the catheter.
Okay. So that is the part.
Yes.
Distal to the catheter. Distal to the stent, you are telling?
No, distal to the guiding catheter. Meaning that proximal lesion, which one we avoided by seeing the diagnostic.
I have just only done the stented segment.
Okay.
to whether it is supposed or not.
So
And
Yes.
when I will pull the wire, you will see that the wire is
Yes,
that
yes.
effect will be gone.
And previously, before starting, we have
Yeah,
seen there is
it doesn't,
no
it doesn't
significant.
look, it
Yes,
doesn't look like that much
yes,
significant,
yes,
because
yes.
you can put stand there, because too much stands in this calcified lesion,
Ah,
the
yes.
patient will come again and again.
oh yeah,
So you
beautiful,
see,
beautiful.
Professor Wu, Professor Wu.
আচ্ছা, ছবিটা দেখান, screen এ ছেড়ে দেন।
so the final peak is like this. I'm not giving because not too much, because the pressure is going down a little bit after GTN also. So you are happy with this one?
And the proximal lesion is not so tight.
And proximal lesion is not that much
Right,
significant,
yes.
maybe. Okay.
Angio. Yes, run it, please.
Do you
run.
want any other picture?
This was the final picture of this patient.
Ah, yes, all right.
So I'm done. Any discussion? Anything else?
Okay, Dr. Professor Rahman, well
Yeah.
done case. But I want to know.
You have, I am just thinking here, and you were taking your lunch. So good.
Right. Now, yeah, I think you are planning to leave this procedure right now, or
Yes.
Yeah, I have finished it.
Why?
Ah, yes.
Without any complication.
First part
In the
of the
proximal part, there is also a carp, acute carp, which also mimics the mole lesion.
Yeah, it is showing us too much
Yes,
like
yes.
the aggressive one, but it's not that much.
Aggressive.
Yeah.
did you?
Thank you.
Thank you.
Thank you, Professor Saidur Rahman, for.
And I'm also thanking. I want to say just to my cath lab staffs, like my cath lab in charge nurse here, Nasima, and scrub nurse Harun, and other people here, Shankar, Nuru, Habib, Shahrul, our team is a great team here. And Amola and Nargis are circulating, I have told. I want to thank them also. Thank you very much. I was really
Thank you.
gosh of
Thank you.
adrenaline was there, but I am relieved now.
Yes. Thank you, Professor Saidur Rahman, for your very interesting case, heavily calcified, both LAD and RCA with heavily tortuous vessel without any without any rota. You have done it as you are experienced in this part particularly, and that is why you where you thought that you will be able to do, and you have proved it that you had done it. And I like to receive comments from Professor Wu. Are you with us, Professor Wu?
So I'm here. So
yes.
we're sorry. So today on the rail station is very noisy, but I'm very happy to see the very successful the case. So it's the left side very calcified and the right side very tortuous, a very long lesion, and without recuperation and without the caster or the Godzilla. So it's the very regular approach. So the team can treat this very tough case without other the devices. I think it's amazing. So congratulations to all the friends. So it's a really successful case.
Thank you very much. Thank you, Mr. Wu, and happy journey for you.
Thank you, Professor Wu, for participating in our second radial live. And first radial live, you have presented live case from Inur Institute, and you are invited to my next year live radial live, Bangladesh Radial Live 2021 in 8 and 9 September. Please block the date for 8th and 9th September 2021. And also thanks to the performer, Professor Rahman and his team. And I like to take opinion from Professor MG Azam. who is one of our panelists here as well as moderator.
Thank you very much. First of all, my apologies for late appearance, as because of
Eating.
some other business. Anyway, but what I did or what I observed, the case really it is excellent is because it is transplantation. But he did it in very simple way so that we can understand that you never become panic. Be calm and quiet and confident. If you have enough confidence, if you then you make the things easy. So we actually learn a lot from this live case. Hope to we switch over our next session. Now we are in time, and next session will start at 4 o'clock. So, and I must appreciate Professor Ramon and his team and his Cath Lab and Ibrahim Cardiac Center really join with us as a development partner or to develop our manpower and to share our knowledge to our friends and colleagues. Thank you very much. Thank you very much.
Thank you. Thank you. Bye.
Thank you all. Thank you, Professor Wu and all other chairpersons as well as our panel of experts.
Who is traveling? Some other place? Professor Wu? Professor Wu, can you hear me? Are you traveling from any other side or city?
Yeah, so all the friends. So I'm very happy to see all of you. So and from a last case, I think in Bangladesh. So in the field of PCI, so it's a big progress. So yeah,
Professor, actually, I want to introduce Professor Azam, sir. Professor Azam sent mask and pandemic time to you last time in the March. So Professor Azam, actually, this is the first time you and Professor Azam communicating. So Professor Azam sent many masks to China in the pandemic time to us. So thank you, Professor Azam, sir, to helping and support us. Thank you. Thank you.
Actually, I want to. We hope to see him in person in 2021 with for our future development or future opportunities. Actually, you know, the legend in China, as I know a lot of colleagues. I think you may know Professor Tao Liang Chen also mentioned your name, so I was really pretty much happy to learn your name in the from the different society, different bodies. So we really appreciate it to join with us in the next year, and hope we will be over in Corona pandemic by this time. So we appreciate your expertise in our future program. Thank you very much.
Thank you, Dr. Misbah, also, as because he is the link between Professor Wu and Bangladesh. And so we are very much proud of our son of the soil, Bangladeshi.
Sir, Misbah is the ambassador of our Bangladesh cardiologist.
Yes.
Thank you, sir. Thank you. So actually, sir, we have many more opportunities to join together, and for the Bangladesh and China is a very well and a strong friend. So many issues we can do together with the help of Professor Wu, with the help of Y Hospital. This is the National Heart Center and the largest heart center in the world. So we are really welcome all of the people who want to join with us. Thank you, sir. Thank you.
Okay, thank you.
Dr. Iftikhar has joined with us. Iftikhar, have you any comment?
Well, sir,
time is over. Even then, I have seen just you.
Yes, sir. I have joined just now, so I will not comment. It's not proper for me to comment right now.
Doctor, thank you. Dr. Ashok Doctor has also joined.
Thank you, sir. Just yesterday, I cancelled one case that was also for your live case for Rota. Today, I did the case that time I was busy, so I completely I didn't see the live case. But anyhow, that was a great case as much I have seen. Thanks Ibrahim Cardiac Center, all the Cath Lab team, and thanks Brick for arranging such a great session. And hopefully I will join the next session in the CD presentation. Thank you, Mir Jamal sir.
Thank you. Then we can conclude the session. Professor Azam, we can conclude the session.
the break is to promote our young generation or our next generation and exchange our knowledge to our development partners, our co-workers and colleagues in different societies like China, India, and South Korea, Japan, like that. And right now you have seen already improving. Already UK and US already work with us. So we hope we will work together and we will develop our manpower for our next generation. And I must give a special thanks to our wonderful audience, actually, who are joining this program despite their corona pandemic schedules. So we must appreciate them, and I hope and we believe you will enjoy already yesterday program a lot, and you will enjoy the next session, which will be much more interesting. A lot of case presentation is there, so we hope we learn a lot from our next sessions. Now I'm requesting our Professor Jamaluddin sir, post director, to the final word and choose the program for next sessions.
Thank you, Professor Azam. Practically, as because the world is going towards the hand rather than from the leg, so why we should behind? We should have to cope with them, and this is our idea, to cope up with the world. As because you have, we know that in USA approximately 70%, in UK approximately 90%, in Europe approximately 60 to 70% radialist. So our younger generation will be radialist. This is our motto, and with this motto we shall go forward. Thank you all participants. Thank you, all the panelists as well as moderator and chairpersons. And now we go to the next session. Our next session, Professor Azam, next session. Yes, our next session is a challenging interactive TRI case presentation. 4:45. It has been written 3:45. Anyway, and our chairperson is Professor Dr. Abdandil Babunsville, who is the pioneer of distal radial approach. Professor Shazal Kumar Banerjee, his family is sick, probably he is not with us, and Professor Athar Ali. And our panel of experts are Dr. Kim, yesterday he also came, Professor Muhammadullah Firoz, Professor Dr. Chandan Kumar Shaha, Dr. Ganapati Aditya from Mymensingh, head of the department, Mymensingh Medical College, Dr. Fatima Begum from United Hospital, Dr. Bijay Datta, he is sick, and pray for him, he is suffering from COVID, Dr. Swadesh Kumar Chakrabarti from Khulna, Dr. Khondokar Asaduzzaman from Asghar Ali, Dr. Tarek Ahmed from NICBD, Dr. Shahriar Kabir from Dinajpur, and Dr. Mohammad Rizwan Rehan. And I here the moderators are present. Professor Azam, are you present here? Professor Azam, you continue this session. I am with you.
So one minute, sir. Okay.
Professor Babunsville has joined with us. Congratulations. Thank you for joining the program from Bangladesh Radial Intervention course. And we know that all of us know that you are the pioneer of distal radial approach. And we have today we have seen you practically, meaning that on video. And we hope that you will give us more inspiration for developing this subject in Bangladesh.
Thank you very much. Thank you for your invitation, kind invitation. It's my great honor to joining this important event. And as I understand in this session, we already discussed about the TRI case presentation.
Yes.
So, and would be a very interesting session, and I'm waiting for challenging cases, and we will discuss about that.
Yes, Dr. Professor Azam, have you got your schedule in your hand?
Sir, can you continue? I just checked this agenda.
As in, I have no also agenda in my hand. That is why just now from Incepta, they have shown me or Incepta because
sir, we are sharing the screen, sir.
Yes, yes.
Yes,
I've
sir.
got the agenda with me. Yes, yes.
Yes. You will have to show it as because in our hand it is not present. First topics is light at the end of the tunnel. Light at the end of the tunnel. Light at the end of the tunnel. Dr. Iftekhar Alam. Dr. Iftekhar Alam is one of the young renowned cardiologists from National Institute of Cardiovascular Diseases. Please, Dr. Iftekhar Alam, show your case.
Thank you, sir, for your generosity for giving me the opportunity to present my case. Well,
We are not hearing.
yes, sir, I'm coming back, just trying to open my sharing slides. Okay, I'm now back. Sir, can you hear me?
Yes.
Yes, sir. Sir. Okay, very Assalamu alaikum and very good afternoon to everybody. Honorable chairpersons, moderators, panelists, and my respected teachers. Good afternoon. I am Dr. Iftekhar from National Institute of Cardiovascular Diseases. Presenting my case. The title of my case is Light at the End of the Tunnel. Before going into my case, I would like to tell something about the background of my patient. He is a 55 years old male, present with exceptional chest pain for more than 1 year, gradation of pain to shoulder and arms. Risk factors included diabetes mellitus, hypertension, ex-smoker, and family history of hypertension. He has a past medical history of STEMI inferior. On October 2014, initially was thrombolyzed, and later on he went for coronary angiogram, which revealed a single vessel disease. And PCI2RC was done on 14/10/2020 with a drug-eluting stent 3 by 30 millimeter in size. Later on this year, on last month, he came to us with these findings. His history was showing just inferior ischemia and ulnar inferior. Echocardiography was quite normal. Other blood parameters and diabetes mellitus was under control. With view of this, we went for angiogram of this patient. Initially, the first view shows the right coronary arteries. Then, on the left coronary artery, another few views of the left coronary artery, where you can easily see the retrograde from left to the right side. If you consider the still picture of angiogram, the more striking event what we can see is that there is a stent in situ in the RCA, mid part of RCA, which has some progressive instant restenosis with distal end is obliterated. There is no flow beyond the distance. RV branch can be clearly seen, and on left side, from left side, you can easily see the retrograde flow. So the series comes like that. Left main is normal. LED statue vessel, SCX, non-significant mid arterial disease, and RCA, there is stent in situ in mid RCA with diffuse progressive ISR with total occlusion at the distal end. The lesion have the PME flow of grade 3, grade 0, and retrograde from RCA to the is seen from the left system. So our decision was to do an PCI to the RCA. So the PCI to RCA. Initially, we took a Japanese right 3.5 6-pin guide catheter and engaged it, and due to the CTO at the lower end of the ISR, we chose a Pilot 150 guide wire, what we thought would be useful for crossing the block. And with some manipulation, we were inside the stent, but beyond that, we cannot proceed furthermore. So over the wire, we took a balloon, 1.5 by 15 millimeter balloon, to strengthen our entry of the stent, and we somehow managed to cross into the distal part of the artery. But after crossing, we tried to track down the balloon along the wire, but we failed to do the tracking. So we thought we might be inside some wrong channel or maybe some small artery. So we went for dual injection from right femoral approach. So for the dual approach, you can see our wire passed through beyond the occlusion into a marginal branch of the RC. After that, we removed the wire and we tried to tracking down following the retrograde flow. And after few chances, we finally entered into the RCA proper. And with the balloon that we had, the 1.5 balloon, we started dilating from the distal end. And we sequentially dilated the whole length of the disease part through initially by 1.5 by 15 millimeter balloon and later on by 2.0 by 12 millimeter PTCI balloon. After dilatation, we can see there are still some changes in the proximal part of the artery. So we did another few episodes of dilatation. Oh, sorry. So after dilatation of the artery, we initially took a 3.0 by 32 millimeter depth and deployed it distally. And after deployment, the artery looks like this. And initially playing the discoid stent, we again take another second disc, which is 3.5 by 35 millimeter, and place proximality with adequate overlapping with the distal stent and deployed at 10 atm. Well, due to some technical glitch, I lost the pictures where the scene I used where I took post dilatation. We posted the dilation initially starting from 3.5 by 12 mm NC balloon and later on by 4.0 by 0.8 millimeter NC balloon, and sequentially dilated the whole length of the stent, including the overlapping part, and final to what it looked, complete revascularization with symmetry flow in the distal arteries. We have used several hardwares. The guide catheter was Japanese right 3.5 with 6-pin wire. Guide wire was 0.01 for Pilot 150, and we have used several balloons, including pre-dilation, post-dilation balloons, and distal 3.0 by 3.30 millimeter, and proximal was Promus Premier 3.5 by 38 millimeter. And I do have some technical analysis. ISR is a difficult scenario for any conventional cardiologist, and if ISR present with progressive lesion, then it always have a high recurrence rate, and due to its distal situation, it is always difficult to negotiate with such conditions. During PCI situation, integrated approach, contralateral injection is mandatory, and in my case, without contralateral injection, it was quite impossible for me to cross the lesion. And it is always mandatory to use integrated dual injection in case where we don't have any integrated breathing collaterals. When a better backup force is required, the wire and balloon anchoring technique is considered. In my case, I don't need any extra backup, but it was quite useful to use the balloon, which helped me to straighten up and cross the lesion. Thank you very much. This is my team with whom I work. My sincere gratitude to my professor, Mamre Rushid, and my fellow colleagues, Dr. Lipi Devnath and Dr. Sadiqul Islam Shikhar. Thank you very much for listening to me.
Thank you. Thank you for your Iftikhar, for your nice presentation. Dr. Anisul Awal, do you want to comment on it?
Anisul Awal.
Oh, this is a nice case, and
he'll present the next case now. Okay, then for the first case, I want to know some comments from Babun's Billy, who is the master of distal radial approach.
Okay. Only one question to presenter. Why did he use the femoral access for this case?
Okay, sir, I didn't use the femoral access. My access was radial. For dual injection, I used the femoral access because on left side I had an venous access. That's what I don't want to disturb. That's why I used.
Probably Babun's Billy wants to know why you did not go biradial. And
no. Biradial because I had a venous access on the radial left side. That's why I couldn't go to biradial. Well, next time I'll try on the both radial side.
Okay.
No. It is not mandatory that I shall have to go to biradial approach, and it is also favorable to do radiofemoral, as because I am on the right side of the patient, and over the patient, if I have to puncture the left side, a bit difficult sometimes. Thank you.
And you, sir, can you take,
yes.
Okay, sir. Thank you very much. Can you take a single or one or two more comment from our panel?
Yes.
Professor Mahmoudullah Firoz also here.
Yes.
Professor Mahmoudullah Firoz, you are here.
May I ask one question to Dr. Iftikhar?
Yes, sir.
Dr. Iftikhar?
Yes, I'm
listening. You took 3.5 GR for CTO.
Yes.
So if you suspect that it is CTO, then definitively with a good backup support catheter, either GR4 or L on is the better choice, because your that catheter, guide catheter, was floating when you were wiring the RCA. So how long that was, that patient, how long back that stent was put? That was in 2020 only.
No. Yes, I just put it back in last month, October 20th. October 11th.
No,
October 11th,
first stent was done. First stent was done.
First in 2014.
14. So definitely, if it is CTO, then your backup support must be good, either M+ or at least GR4.
Yes, I agree with you definitely, but sometimes we don't have the M+ at that time at my lab, so I have to first go for the GR3.5 GR, and I somehow managed to do that case. This is the main thing.
Thank you, Iftikhar. I just take a just impression from you, then I go to Professor Maksumul Haq sir, because as you know, the primary diagnosis was inferior amide in 2014, old amide. Then he is intervened by PCI in RCA 2014. Now patient came to you with ISR and in the form of CTO. Do you consider it is very late stent thrombosis? Very late stent.
Most likely the thrombosis process. That most likely it's the thrombosis. It's it began from the very beginning or very few years back. The late instance thrombosis started. So I consider it as ISR, not like other things.
And other thing that is very important for any ISR is IVUS.
Yes.
I think you did not do it at that time.
Okay, we don't have the facility of doing IVUS in every lab. The lab I used at the day, you don't have the IVUS facility.
Yes.
Really, may I have some comments about this case? And Dr. Gutta, I totally agree, because in case such this, we always use one of the visualization technique, OCT or IVUS. First of all, we can detect reason of instant restenosis or stent thrombosis, malposition, undersized, not optimized at primary PCI. And secondly, we can surely detect landing points to avoid excessive metallization of the artery and implant the correct diameter and correct length of stents. And I think it's my position that in case of in-stent restenosis of thrombosis, visualization is highly recommended.
I must appreciate.
Thank you, Dr. Bhuvanesh. Actually, I am very much glad to see you. When I started distal radial and I go through the papers on internet, from that time I was imaging your face, but you are really more young and more glazy than the photo that we usually see in the net. So I think you should put your real picture in net.
Okay, I get it. I get it. Thank you.
Thank you.
Okay.
Thank you.
For your kind information, Dr. Babans Beli, we including Dr. Ashok Datto, we always use your picture in our session when we talk on distal radial approach. Thank you.
Thank you.
Next, Azam, time is over.
Thank you. Now we can switch our second case. I am requesting Dr. Anisul Awal to present his case, My Radial Challenges. You have a challenge. You please present your case and you should express your radial challenges. We are eagerly waiting for your case. Dr. Anisul Awal, can you share your screen?
Thank you, Professor Ajam, for your kind introduction. Honorable Chairperson, respected panelists, and the August gather. Very good afternoon, everybody. I'm Dr. Anisul Awal from Chittagong. So my talk will be my radial challenges. My first case, swinging on a thread. Mr. is 49 years, diabetic, having still smoke, chest pain and diagnosed as acute ST elevation MI and thrombolized with STK. ECG ST elevation from V1 to V5, and there is a regional wall motion abnormality, ejection fraction of around 45%, and CAG transradial root shows osteoproximal 95 to 98% lesion. So we went actually for pharmacoinvasive. Patient had symptom despite the thrombolysis. Heparin 10,000, guide catheter we took EVU, 6 French, and BMW aware, and we take for pre-dilatation 2.5 balloon, and stent was 4 into 15, everolimus drug-eluting stent. So that's our NGO. As you can see that there are several challenges in these cases. This is big LG just swinging on thread, it's like that. And ostium is involved. And we want to put the stent, not to miss the ostium, and not to also put our stent into the left main so that we do not encroach upon the LCX. So that was our motto. And we carefully try to pre-dilate first. And after pre-dilatation, we took the stent, and after different orthogonal view, we try to make sure that our ostium is not missed, and at the same time, we do not put much metal in the left main. So with this different view, and we try to optimize our work with the stand view that we have in our cath lab, but we don't have IVUS, so we try to do what we have in our hand. And with this, as you can appreciate, we tackle the lesion very well. That's the final result. So my next case is double bifurcation with left main disease. This is the story of Mrs. RB, 55 years. His hypertension is the risk factor. She had the chest pain and diagnosed as TMI, thrombolyzed with STK, and she was presented with cardiogenic shock. ECG ST elevation, B1 to B4, echo RWM present, and ejection fraction around 45. And transradial shows there is left main disease, 50% stenosis at mid to distal LG, and 95 to 90% stenosis proximal to mid segment. And ostium of the LG also shows the lesion. So we took the heparin, guide catheter, EVU, 6 French, and we took BMW and all-star wire, and we took the for pre-dilatation 2 and 2.5 balloon. And we need here 2 stent actually, and one is 3 and another is 3.5. So this is the right side, which is okay. But at the left side, as you can see, there is a lesion standing from the mid part of the left main, distal, as well as ostium, and it's actually the long lesion extending up to the mid part of the LG. And there are actually, we have two challenges. There are two bifurcation we come across. One is between the D1 and LG, and another one is between the LG and LCX. And also there is a lesion in the left main. So as the lesion, we just go ahead with the first pre-dilatation, and then we plan to have a long stand. As there is size mismatch, we try to put a longer stand, size stand in from the distal to proximal part of the LG, and also put a wire in the D1, so that if there is anything happen, then we can recross or we can do some. So we did a provisional actually, and we made a part also, so that the optimized, and we found that there is D1 is not actually compromised. It remains as usual. So now then we concentrate on the left main lesion. So there are two challenges. We decided to go up to the left main ostium. So make sure that we have to cover the ostium. At the same time, we do not want to overhang the stand. And we could keep a floating wire, so that we can have a guide of the ostium. At the same time, not pushing the guide catheter to the stand and injure the stand. So we have already wire in the LCX, and after putting a stand, we found that there is LCX is pinched actually, and we cross through the stand to start wire, and then we put a balloon 2.5, and we dilate, and then we make a kissing balloon inflation, and also make a final part. And with this, you can appreciate that the result, final result. So then, let's move to the third case, when balloon and stand are not crossable. This is a profile of a octogenarian 80 years old male, diabetic hypertensive, inferior MI, regional almotional present, and CAG shows single vessel disease. So guide catheter here, JR 3.5, Xion blue is the wire, and we took several balloons for pre-dilatation, 2 and 2.5, and stand was 3.5 into 23. So this is the one seen a loop here. As you can appreciate, this is a right corner. It is a hugely tortuous vessel, and there is a challenge of age itself is a challenge, and the force is also a challenge. And the RCA, we didn't get much support from the guide. We tried to put the Xion blue wire, and with much difficulty we cross. And whenever we try to put the pre-dilated balloon, there is everything is trying to come out. So we put another body wire also, but this did not also help. So with much age, we just not able to pre-dilate the whole lesion. Then we bring the guidezilla into action, and then our job become easy. We can put the balloon for pre-dilatation, and also we can put the stand, and also we can make the post-dilatation with ACE. So with all our efforts, we are able to do it. And as you can see, the final result here. Yeah. So there is, in this COVID era, we have, this is my last case with a COVID challenge. This Mr. PM, 41 years. She is a staff of Chittagong Medical College. History, only smoking is the history. Chest pain for 3 hours. Diagnosed acute ST elevation in inferior, and planned for primary PCI. ST elevation to 3 ABF. Reciprocal changes in V1 to V3, and echo shows regional wall motion abnormality. And we can see the transradial route to the angio. Patient presented challenges in the COVID era. No history of fever, cough, sore throat in the recent past. No trouble history or no history of contact with the COVID patient. Chest X-ray was normal, and we arranged COVID test urgently, but report was not readily available. And moreover, that he had a history of head injury in recent past. So cath lab fortunately was free on that time with the all level 3 protection. We went to the cath lab. Heparin 10,000, transradial catheter JR 3.5, Xion blue is the wire. We pre-dilated the 2.2 into 10 balloon. So the challenge is actually not the case, but the scenario and the timing, because all thrombolytics draw now the preferred choice because of the patient have the head injury in the recent past, as well as he's the staff of the CMC. There is huge pressure of do something right now. So we took the thing and we were able to cross the lesion with much difficulty, but with the support of a small balloon. But there was a slow flow and no flow was the issue. But finally, with repeated daughtering and GTN, we able to put the stand, and we didn't do the post dilatation actually, and we try to optimize our work by the stand view, and finally, as you can see, that there is a Chini 3 flow. So that's all from my side. Doing challenging cases, complex cases in a resource limited center needs logical approach, perseverance, and teamwork, where must not be lost at any time during PCI. For difficult distal cases, guide support is essential. To increase support, sometimes we may need guide extension catheter like GuideZilla. So intervention is really challenging, like climbing a date tree. There are many challenges, but if you can overcome, but there is at the end of the tasty fruit juice like this. Thank you. Thank you very much for your patient hearing.
Thank you, Dr. Anis Lawal, for your galaxy of cases. As because you are outside Dhaka, you are doing cases in Chittagong where there is no, where there is limited resource. In that resource, you, within that resource, you have done several interesting cases. Thank you once again. And I like to draw the attention of Dr. Babunsvili for his cases.
Thank you. I have only one remark about the first case, osteal lesion of LAD.
LAD.
Yeah, right. So according to the latest statement of European Bifurcation Club, this lesion we should recognize like as the bifurcation lesion 010 Medina type bifurcation. And
yes,
consequently, we should all of that elements of bifurcation stenting technique, proximal optimization, kissing, final optimization, and do not hesitate to over dilatation stent part into left main. So I would say that in that case, we should, I don't know, it's maybe not the optimal approach, but we always used a cross stenting for full and reliable covering of a lady osteo. And after that, of course, over dilatate in the left main part of stent,
yes,
and all of that elements of bifurcation, provisional bifurcation stenting. Only one remark about all of the 4 cases.
Meaning that if there is a ostial left anterior descending artery disease, we shall have to think that there is also plaque in the distal left main, and so it is better to cover. Is it your comment? Okay, thank you. And Professor Azam.
Yes, thank you, sir. Actually, so far I can understand Babu's comments. So when you classify Medina classification, EBC also recommend to routinely use to practically approach bifurcation stenting strategy. We should use Medina classification. And number 1, if you classify into 010, it is not a 010. That means
yes,
it is not true bifurcation lesion. Actually, true bifurcation lesion. In that particular situation, definitely we should go for single strategy. As because you see the case, osteal LAD always means there is at least 1 or 2 millimeter, or some extent it is extended into the left main disease. Sometimes naked eye cannot be evaluated very properly, so that I must give you the right estimation how to interpret or how to interrogate your lesions. So I think in that remote place like Chittagong Medical College, without the logistic support, Dr. Anisul Awal did a great job. We should appreciate it first of all, and we should recommend at least first 30, 40, or 50 case. If you did it under the guidance of IVAS, then you have when you get confidence, then you can go for this routinely. You can go for this. This is my just recommendation. By this time, I just bring Dr. A.K. Manor Islam. Please come forward and you take over the charge to continue the session and moderate the session as well. Dr. Manor, A.K. Manor Islam.
A.K. Manor. in
Dr.
this
Paul,
session.
I'm seeing you in this screen.
Yes, yes.
Okay.
Thank you, thank you.
Your virtual picture is also very nice.
And Dr. Ashok,
Thank you, sir. Thank you, sir.
Dr. Ashok Datta, can you make any comment regarding this Anisul Awal case? Actually, you know, he already showed galaxy of case. I think, I'm not sure whether you can memorize first, second, third, fourth.
Yes, yes.
When you can memorize, you can make comment or you can use recommendation.
Yes, otherwise difficult to comment. We have also time.
Please unmute yourself. Please unmute yourself.
Ashok, unmute.
So thank you, Dr. Ajum. Anisullah Awal is very close to me. I definitely thanks him very much because at a remote place in Chittagong, without big logistic and other support, he is doing a great job. Definitely, Anis, I think you should go forward.
Next, Dr. Akem Monol Islam, you take part.
Thank you, sir.
As moderator.
And now is the turn for the third presenter. Today's third presenter is Dr. Gautam Swarup.
You please maintain time.
Yes, he will present on best bifurcation stenting, the real chip in acute coronary syndrome. Dr. Gautam Swarup, please.
Dr. Gautam, are you?
Yes,
with
yes,
us?
yes, yes.
Okay,
I would like to thank all esteemed faculties and young operators of Bangladesh to give me this privilege to present my case on your forum. And it's a good forum to just learn the young operators how to manage cases via the transradial approach.
Yes.
So I will show you a bifurcation stenting in a cardiogenic shock scenario. And I hope it will be a good case to discuss regarding the strategy, regarding the planning, and regarding the follow-up of the case. So it was a 70-year male, and he was a smoker as well as COPD, basically depend on the oxygen, and with poor lung capacity and known diabetic since 4 years and on insulin. He was having severe claudication pains. For that, he was undergone aortoiliac bypass 8 years back. And he presented with the resting chest pain and acute shortness of breath since 2 days. And patient was on BiPAP support. At the time he presented in my hospital, he was on the BiPAP support and severely dyspneic. Blood pressure was like 100/70, and he was on the NORAD at 3 or 4 probably. Pulse rate was 98 per minute. Serum creatinine levels were 1.9 at that time. ECG shows QRBB and ST coving from V2 to V6. I did his echo, and echo shows LAD territory severely hypokinetic, and his ejection fraction was 34%. And this was the brief medical history of that patient. And the finally diagnosis was settled as the anterior wall MI, non-thrombolized, ongoing chest pain, acute LVF, cardiogenic shock, and with nephropathy. With this background history, I have proceeded to do the angiogram. Definitely it was the radial route because the femoral route was not possible. And as you can see this angiogram, and you can easily assess this, that the right system is almost normal. Left long, left main with the dual LAD, and it was Medina 111. It was an LAD T1 bifurcation. Patient was pretty lucky that he was survived on the thread-like main vessel disease. So I would like to discuss what is the technical challenges and what is my action plan. So considering the age, comorbid conditions like diabetes, COPD, nephropathy, and low body weight, patient was definitely considered as the high risk PCI. Patient was in cardiogenic shock. As I told you, that patient was having poor LV function, and he was on BiPAP support and on the vasopressor support as well. So it made me very challenging to proceed with the PCI considering this angiographical picture. So considering this angiographical picture, I decided to go with the dedicated two-stent strategy because the narrow bifurcation angle, it was a key deciding factor to plan which type of strategy I should adopt and start with. So I adopted the decay crush technique. Why it was chosen? It was chosen because it is the best strategy considering anatomy and long-term results in the various trials in the evidence-based guidelines. So rapidity of the procedure, clarity of the step with the minimum contrast usage with the possible aggravation of the nephropathy was the key determinant of the success in this primary PCI. So I went ahead with the femur because the femoral exit could not be taken. Definitely the route was the radial. I went ahead with the 6F guide cath with the 2 fielder FC wires and VisiPack contrast media to minimize the nephropathy risk. So that was the problem was to start with that the poor guide support due to the long LMCA and probably tortuous aorta. EBU was not properly seated right from the starting of my procedure. That was the very problematic, and I was very scary to some meshy things should happen in between my case. So to start with, just I pre-dilate with the 2 into 10 millimeter vessel, a semi-compliant balloon into main vessel. Then I pre-dilate to the side branch with a 2 into 10 mm balloon. And then I did the side branch stenting, diagonal stenting with the DES 2.5 into 20 millimeter at 14 atmosphere. Then I removed the stent as well as that stent balloon and the wire and performed the first crush. Unfortunately, I don't have a picture, but I did the first crush at this point of time. Then I did the first kissing with the 2.5 into 10 and 2.75 into 10 into LAD with the non-compliant balloon at 12 atmospheric pressure, as you can appreciate this. And after that, I did the main vessel stenting. It was a DES of 2.75, 16 millimeter at 14 atmosphere. Then I did the first pot with the 3 into 8 millimeter balloon. You all know that the pot enhance the recrossing of the wire and the so that the wire cannot go into the false channel or behind the strut of the stent. That is why I did the first pot with a 3 into 8 millimeter into the main vessel. Again, I did the side branch rewiring by after the first pot. Then the final kissing, I did the second kissing with the 2.75 into 10 and into 2.5 into 10 into diagonal with the 18 atmospheric pressure. And finally, I did the final pot into 3 into 8 millimeter and see at the 18 atmosphere. So it was the final result. As you can appreciate, there are the well-flowing dual LED with the LED demon bifurcation of the decay crush. So my take-home message from this case is almost equal side branch with the osteoproximal disease always need the dedicated two-stent strategy. Debate can be done regarding the what strategy in which operator and which he was is, and adaptation of the particular technique depending on the bifurcation angle, size of the side branch and the operator is. Operator should master any technique of which he can feel confident and comfortable to avoid the complication during the procedure. Bifurcation technique in primary PCI should be treated as a different subset, and it always be debatable regarding the choice of the bifurcation stenting and the performing decay crush in particular this case in acute coronary syndrome with LVF and cardiogenic shock with poor LV is the real chip. And decay crush technique is considered best in current scenario if operator has enough experience with this technique and from the long-run results. Thank you.
Thank you. Thank you, Dr. Gautam Swarup. We are really happy to hear from Lucknow. Thank you very much.
Same here.
Thank you. Dr. Mohammedullah Firoz, are you with us? Dr. Khondokar Asaduzzaman? Professor Babunashvili, do you like to make any comments?
Sure. Okay, so only short comment. My congratulations, excellent demonstration of classic decay crash in very challenging situation and absolutely amazing final result. So, but
Thank you.
in this case, when we have a huge plaque burden involving the side branch, especially in case of equal side branch diameter as a main branch, then the two-stent strategy is preferable. My question is to you, what about the guiding cutter size? 6 French is comfortable for you? What about the tactile feeling? Or maybe 7 French is more preferable in this situation when we use the kissing balloon, even the balloon and stand, simultaneously advancing into guiding catheter. What about these? You always use 6 French, or sometimes you prefer 7?
Dr. Avendil, this is the great question you have asked me. There is some considerable things regarding the choosing of the guiding catheter. Definitely, if you use a 7F guide catheter, it is the best way to do this case, because 7F catheter definitely gives you the great backup support, and you have to if you have to implant the 2 stands and wire with balloons, then definitely 7F guide is the good. But in this particular case, the patient was having a low body weight and thin structure. Definitely, if you take the glide sheath slender, like it is the Terimo glide sheath slender, probably do you know that with the use of the GSS sheath, you can upgrade the 7F guide to any of the patient. But in this particular case, the patient was having lean build and low body weight. And again, if you feel that you are doing the left main bifurcation, where you are your stent would be like 3 and 3.5, then 7F guide is the better option to choose. And if you feel that you are going for the LED-D1 bifurcation and you are going to implant the 2.5 or 2.75 stent, then you can do it easily. But again, you are very right. If you have option to upgrade the guide catheter with the 7F, definitely you should proceed with the 7F guide catheter.
Dr. Babunashvili, thank you for raising the question, but I want to know from you how much you are comfortable with 7 French guide in the distal radial approach.
There's some small difference in diameter between traditional radial access and distal. It is around 0.02, 0.03 millimeter. But if you use this, for example, slender sheath, there is no difference when we use even 7 French guide or sheetless guide. We often use the sheetless guide through the distal radial access when we're stenting distal left main, or maybe when we use the biradial access for complexity or recanalization. In general, my gut feeling is that there's no difference when we use the traditional distal radial access, because recent technological advances allows to perform all kind of peripheral or coronary procedures, what we did before these through the traditional radial access.
Thank you very much. Our 4th presenter is Dr. Lima Astin Sayami. She will talk on when IVAS makes difference in decision making. Dr. Lima Astin Sayami, please present your case.
One of our young interventionalist, Dr. Lima, who is trained up in Malaysia with Dr. Rosli for approximately more than 1 year. So let us see her case.
Thank you, sir, for your kind word. Honorable Chairperson, respected panelists, and learned audience. A very good afternoon. I'm Dr. Lima Astin from NICVT. Today, I'm going to present cases to show how IVAS makes difference in decision making. My first case is a 55-year-old gentleman who presented with chronic stable angina, and the stress test was positive in first stage. On examination, he was severely anemic. During evaluation of cause of anemia, pararectal bleeding was found. Colonoscopy was done, and it revealed rectal carcinoma. Surgeon wanted to settle the cardiac condition before surgery. So we did the angiogram, and the angiogram revealed there was about 95% stenosis in the mid-LAD. There was about 50% stenosis in the osteoproximal part of the left main. Here, if you consider the diameter of the left main, it is about 50% reduced if you compare with the diameter of SARC or LAD. So we took another non-selective view. So here also seems to be significantly reduced left main diameter. So this patient had multiple issues. So where to stent, whether the left main should be stented or not, which stent should be used, whether bare metal or drug-eluting stent, how long DAPT should be used on the background of active bleeding and urgent surgery, and when to do the surgery. So to have a clear idea about the coronaries, we did the IVUS, and the IVUS revealed the LAD was diffusely disease involving the distal, mid, and proximal part. This one is the mid part of the LAD, which is most significantly reduced in diameter with a huge plaque burden, and proximal part also has plaque burden. But the left main seems to be mildly diseased. So when we measured, the distal left main had a minimal luminal area of 3.8 millimeters square with a plaque burden of 56%, where the mid LAD had a MLA of 2.0 millimeters square with a plaque burden of 80%, and the proximal LAD had a MLA of 4.2 with a plaque burden of 61%. And the left main osteoproximal part had a MLA of 9.7% with a plaque burden of 30%. So we decided to stent the LAD, and we stented the LAD with 2.75 into 32 millimeter drug-eluting everolimus eluting stent. And the size and diameter of the stent was guided by IVUS, considering the landing zone, keeping the landing zone less than 50% in mind. We post-dilated the lesion with 3.5 into 15 millimeter balloon, and this is the final picture. This is the IVUS after PCI, and we can see the stent is well approached. So here we can see, this is a still picture where you can see the distal, mid, and proximal LAD stent is well approached. My second case is a 45-year female who presented with chest pain, and the ECG showed inferior ischemia. It's normal with the ejection fraction of 55%. Troponin was borderline raised. The left system was normal, but the guide catheter was deeply engaged in the right side, and it showed about 90% stenosis in the osteoproximal part. So we made the catheter coaxial, took another view, and here also it seems to be 90% stenosis in the osteoproximal part, but we were not sure whether this was due to plaque or this was due to spasm. So we gave 200 mics nitrate and took another view. Here it seems about 60-70% lesion in the proximal RCA. To have a clear idea about the coronary anatomy, we again did the IVUS, and we can see about, the osteoproximal part of the RCA has about 80% plaque burden, and MLA was 2.5 millimeters square. It's the osteoproximal part of the RCA. So we decided to stent the osteoproximal part of the RCA and stented the lesion with 4 into 12 millimeter stent, drug-eluting stent after pre-dilating with 3 into 8 millimeter balloon. And we post-dilated the lesion with 4.58 millimeter balloon, and the IVUS post PCI. The minimal stent area was 15 after PCI, and the stent seems to be well approached. And this is the final picture. So my third case is a 70-year-old patient who presented with chronic stable angina. The ECG showed anterior ischemia. The echo was normal. In angiogram, there was about 90% stenosis in the osteoproximal part of left main. So we decided to do the IVUS, and the IVUS showed the MLA of 2.2 millimeters square with a plaque burden of 89% in the osteoproximal part of left main. So after pre-dilating with 2.5 12 millimeter balloon, we stented the lesion with 4 into 15 millimeter drug-eluting stent. And we did IVUS post PCI. Here we can see that the stent is not well apposed in some places, and it showed under expansion of the stent. So we again post dilated the stent with 4.58 millimeter balloon, and again did the PCI, and now the stent seems to be well apposed with a minimal stent area of 14.2 millimeters square. And this is the final picture. My fourth case is a 55-year-old male who presented with chronic stable angina on the background of diabetes and hypertension. The echo was normal with the ejection fraction of 58%, but the patient had ATT positive in the second stage. The patient was admitted for PCI to LAD, having angiogram done 1 week back. So when we engage the catheter, in aerocranial view, the left main ostium seems to be significantly diseased. But in other view, the left main had some haziness, but we didn't have clear idea on angiogram. But the ostium of the LAD had 60 to 70% stenosis. So we did IVUS again, and we can see the left main ostium had MLA of 4.7% with a plaque burden of 59%, and LAD ostium have a MLA of 3.1 millimeters square with a plaque burden of 59%, and LAD meat had a MLA of 5.6 with a plaque burden of 47%. So we decided to stent the left main from LAD. So we stented the lesion from left main to LAD proximal and post-dilated the left main with 4.5 into 8 millimeter balloon. And this is the final picture. We again did the IVUS after PCI, and the stent seems to be well apposed. So why IVUS? So in angiogram, we see views like shadow like this, but when we have a clear view, this may be something different. If you consider the guideline, my first case, we have done the angiograph, we did the IVUS of angiographically 50 to 70%, 50% left main lesion. In the second case, we did IVUS of RCA with a 50 to 70% lesion. And in the third case, we did IVUS to guide the left main stenting. So I finished my presentation with this quote that a clear vision like IVUS back with definite plans give you a tremendous feeling of confidence and personal power. Thank you all for patience hearing.
Thank you very much, Dr. Lima Astin Sayami. You have aptly shown the beauty of IVUS in the setting of PCI. Dr. Khaled Mohsin sir, are you with us?
Yes, Anwar, I am with you.
Yes, yes.
Long time.
Please
Yes.
make some comments.
Yes, Lima has presented very nice cases. She is one of the most brilliant cardiologists of the younger generation of this country. I congratulate her on her very nice presentation.
Thank you, sir.
But before I make a final comment, in evaluation, particularly by the fluoroscopy or sonography, to look at the left main ostium, I think the eleocranial view is a very good view. But in your left main ostial cases, I couldn't see any eleocranial view. And another thing, that the GTN, before you evaluate the IVUS or other things, the pre-GTN and the post-GTN comparative view was also not clearly seen. So, but it was quite obvious that these are the cases. But in the centers where there is no IVUS, because many of the centers, they don't have a IVUS, but it is a the GTN injection is almost mandatory for all osteal lesion evaluation. So it is important. And another thing, that after you did the osteal stenting, we didn't see any view of the osteal flaring. This is almost mandatory in all cases. Unless you flare the ostium, the subsequent procedures will be very difficult. And there is a specialized balloon which is used somewhere in some cases, the osteal flash balloon, though it is not available in our country. But the osteal flaring has to be done in the left main and the RCA ostium in all intervention cases. Thank you.
Thank you, sir. Professor Babunashvili, do you like to make some brief comments?
Short comment about the first case. First of all, my congratulations for the brilliant demonstration of role of visualization, particularly IVUS, when we face to indeterminate lesion in left main, particularly, or in any point of coronary tree. But what about the choose of stent type? There's some myth about the bare metal stent in especially high bleeding risk patient, that we should implant bare metal stent because bare metal stent endothelialized more quickly than drug-eluting stent. But this myth not baked for evidence-based. And the recent trials, I mean the Science 28 and 90 or Onyx 1 trial or Evolve about the synergy stent, all of the trials once again confirmed that we should use always drug-eluting stent instead of bare metal stent, even in high bleeding risk patient, because those trials shown that the safety issue and efficacy is quite better than bare metal stent. And bare metal stent, according to the latest European Society of Cardiology guidelines, we should throw out this type of stent, and there's no clinical or angiographic conditions where the bare metal stent would be more preferable than drug-eluting stent.
Thank you, sir. Thank you. Now is the fifth presenter. She is still a very young cardiologist, international cardiologist
I have
at this
question
time.
regarding this last case.
Please.
May I just ask
Yes, yes.
on query?
Yes, yes.
To respected chairperson, Dr. Babunath, regarding the ostial left main, many a time I faces the problem with non-compliant 3.5 balloon pre-dilatation. After putting the stent, it looks like well inflated, but there is a recoil. So what is your thinking? Does the cutting balloon or anchor balloon pre-dilatation is helpful in ostial left main lesion?
Yeah, sure. In this case, we used cutting balloon or cutting balloon is the most useful in this situation to avoid the recoil, and after that assess by IVUS or some visualization technique to make some decision what we should do after that. So it's the good note, because always when we face to osteal lesion, we should always be sure that this lesion is caused by by plaque, by atherosclerosis. But if we have no atherosclerosis, is there some evidence what we should do when we not have a plaque in this position? I don't know, because there's in some cases slit-like lesion in left main ostial lesion. There's no atherosclerotic basis lesion. But I don't know what we should do in such cases when we have not plaque in left main ostial position. Okay, if we have plaque, the strategy is clear to stent this if this lesion is hemodynamically significant. But what we should do if we have slit-like lesion in left main ostial, I don't know what we should do in this situation.
Thank you, sir. Thank you.
Thank you, sir. Thank you, sir.
Next question.
Yes.
Yeah, many young patients, particularly females, they present with some aorto like Takayasu disease and other things. So would your stent choice will be different in this group of patients compared to an atherosclerotic lesion? In young females with only ostial lesion, no atherosclerosis?
I don't know. First of all, we should assess how hemodynamically significant is this lesion. Because if we put a metallic foreign body in ostial position, we should realize that in follow-up, risk of restenosis is maybe unacceptable high. And we should avoid stenting in ostial position, especially in young women. Because we will face the very serious problem in follow-up when restenosis will appear.
Thank you, sir. Thank you, sir. Dear audience,
and for Dr. Manohar, for all practical purposes, so far my experience, the aortosteal lesion is fibrotic and it requires vigorous post-dilatation to flare up. Thank you. Next.
Thank you, sir. Thank you, sir. Next.
Would you advocate some immunosuppressive therapy as well in young females with aortosteal lesion? Because these lesions, they tend to recur, this type of lesions in future if only angioplasty is done, because this is a systemic disease and it can affect other segments of the coronary tree as well.
I think this is advocated for the overall treatment of Takayasu's disease or like this things.
Exactly.
And this may be part of the overall management of the disease. Next, Dr. Tunagina Afrin Khan. She is also a young interventional cardiologist working in the United Hospital, Dhaka. She has asked for naming her baby. Her title, the title of her presentation is Name the Baby. Dr. Tunagina Afrin Khan.
One of the youngest interventionalists.
Thank you for a very kind introduction. Good afternoon. My patient was a 62-year-old hypertensive diabetic gentleman who presented with a history of old anterior myocardial infarction. At the time of presentation, his ejection fraction was around 40%. This is his ECG at the time of presentation showing anterior MI. So he underwent coronary angiogram showing critical lesion in the ostial LAD and also the distal LCX. Branches were also diseased. He also had critical lesion at the PLV. While doing the coronary angiogram and moving the catheter tip from left side towards the right side, we had to give some non-selective dye while moving the catheter tip from left to right. And we had a glimpse of some accessory vascular structure. So after doing the coronary angiogram at the right side, we engaged our catheter and we found this. We can see some extra coronary arteries here, which are giving supply at the territory of the diagonals and LCX, and also having the collaterals, giving the collaterals up to the septum. These two vessels had a separate ostium from the left main, and the origin was also from the left posterior coronary sinus. So which artery is this one, and what should we call it? So obviously this was an anomaly, coronary artery anomalies, and anomalous coronary arteries occur in about 1% of the population, and most of them are usually benign. So there are many classifications for anomalous coronary arteries, like some are with shunt and some are without shunts. Some have aneurysms with congenital or acquired. Here we can see some pictures of the anomalous coronary arteries, like the origin of the left artery from the right system, or single coronary arteries. Here we can see actually double LED. Some call it double LED, or it can be called big diagonal. We can see some anomalous origin of the RCA from the high up origin above the sinotubular ridge. And the course of the course of the coronary artery can also be anomalous. Here it is the course of the coronary artery in between the aorta and the pulmonary arteries, which is obviously a very serious one. In these cases, this patient may have sudden cardiac death or critical coronary ischemia. These are some anomalous course of the coronary arteries. Here the RCA is coursing in front of the pulmonary artery. Transeptal course. Some coronary artery has congenital hypoplasia, stenosis, or atresia attributable to some other genetic diseases. Here we can also see the coronary artery, congenital atresia here, right coronary artery, right coronary artery. And here we can see the absent left main, and all the left system is supplied by the right coronary artery. And there is also coronary artery anomalies with shunt, like some fistulas are there. And L kappa is another serious anomalous coronary artery, and most of the children die within first year of their lives. So there's on most of the coronary artery anomalies are benign, but some they are serious, may cause sudden cardiac death, so need some surgical corrections like L kappa and coronary artery origin from the different coronary sinus, like right from the left coronary sinus and right coronary from the left coronary sinus. So there is also a variability in definition between whether anomalous coronary artery is truly anomalous or it is a normal variation. Most of the cases, the anomalous coronary arteries are defined as anomalous when it is present in less than 1% of the population. And the commonest coronary artery anomalies is separate origin of LED and LCX. This is a study done in 1990 in a series of 1950 angiogram. The commonest coronary artery anomalous was found, anomalous origin of the right coronary artery arising from the two separate ostia. In a large series of coronary angiogram, that is 120,000 coronary angiogram showing different types of coronary anomalies, but they didn't mention any accessory coronary arteries. So indicating that if we find any accessory coronary arteries, they are extremely rare variety. And most of the cases, they are better defined by CT coronary angiography. This is one of the case report that is found, which is known as the Khan-Malek coronary artery anomaly. Here we can see an accessory LED which runs parallel to the LED, main LED. This is the LED which was previously stented, and this is the anomalous LED. That is the accessory LED artery. But in our case, we didn't find any accessory LED. It is totally different ostium giving rise to different arteries, and both of the arteries was around 2 millimeter around 2 millimeter in diameter, running perpendicular to the left anterior descending artery, and terminating along the interventricular septum and lateral wall of the left ventricle. So, considering the extreme rarity of this sort of coronary arteries, we want to call it the Shofik's anomaly, following the name of the primary operator. Here I mention my consultant, Dr. Abu Muhammad Shofik. I think he is present here. So we like to call it Shofik's anomaly. And thank you for your patient hearing.
Thank you very much, Dr. Tunak Gina. May I invite any comment from Dr. Shofik Bhai? Are you here?
Yes, I am here.
Please make some comments.
Yes, actually, suddenly I could get the artery because I always do angiogram by moving the tip of the base of the half of the catheter. So I don't take my hand in the two places, rather in one place, the half of the catheter. That is why I always try to give some dye, maybe half ml, so that I can get the ostium easily, so that if there is any sorts of disease in the ostium, I can see it easily. That is why I usually do it like this. That is why I could get this vessel suddenly, and which supplying the diagonal territory as well as the septal territory. So it is totally different ostium, and much away from LED ostium and RC ostium. So this is really rare, and I asked Dr. Tunak Gina, just search out this sort of anomaly can be seen in any study or anywhere, but she could not get this vessel anywhere. Actually, whether he is going to give the name by my name, I don't know. That is her jurisdiction. That is, I did not tell her to give the name by my name, but it is her generosity has given my name this coronary artery. This is really rare. So if there is any source of comment from the expert opinion, whether they could get these sorts of anomalies anywhere. But I asked my consultants, Dr. Mohammad Jaman, Dr. Kaisa, Dr. Fateh, even Dr. Rayan Anis, they did not find these sorts of anomaly ever before. So that is why the curiosity that these sorts of anomalies can be presented to anywhere, so that it can be sorted out that this sorts of anomaly is there anywhere to see. Thank you. Thank you very much.
Thank you very much.
Thank you for your presentation. And
Professor Mir Jamaluddin sir.
Yes. Thank you, Tunak Gina, for showing us a new horizon. I like to add one thing. Have you done the CT coronary angiogram?
No, sir. We didn't do the CT coronary angiogram. We referred the patient.
After the procedure, whenever we have found there is a different coronary arteries which we do not usually see and which is not in the literature. So if we can reinforce its diagnosis, then I think CT coronary angiogram will give us some new clues.
Actually, we had we had a plan to do CT angiogram
for scientific purpose.
Right, sir. But
Yes.
patient, actually, I asked the patient to do CT angiogram, but patient refused to do that because patient was intended to do bypass surgery, and at the same sitting, patient did the bypass surgery. So I had a plan. If in the next future patient came to me, then I will do an CT angiogram. That is my plan, sir.
Yes, before surgery, you will do it by your own cost for academic purpose, and we are very much that you have given.
Dr. Monowar, I have a comment here.
Sure.
Yeah,
Sure,
Dr.
please.
Shofik, I think your name has been entangled with an anomaly.
rather than infection.
Thank God, sir, it's a benign anomaly, sir.
Benign anomaly. That is
Whatever,
also
whatever,
true,
it's an
and that is
anomaly.
disease free. More obviously, this is disease free. That is very important. All the
Yeah,
vessels are
even then.
diseased, but this anomaly is benign and disease free. That is also important.
That is also a positive way.
As sir has mentioned, we like to see your name in the literature. Professor
Yes.
Babu Nashville, do you like to make any comments, or do you encounter such types of anomaly in your life?
Yeah, okay, I'd like very well the new name of this anomaly. And I think we should note this name, this new classification of this coronary anomaly. Okay, so we know the different type of original distribution coronary anomaly, but we should correct only in cases when it cause some myocardial ischemia, because all of the anomaly as usual are symptomless, symptom-free. And only two option when large coronary anomaly lies between two large vessels, I mean the pulmonary or aorta or Al Kappa, they cause the myocardial ischemia and need to correct, surgically correct. But sometimes it's helpful because it gives some collateral to distal part of CTO vessel. And sometimes it's useful, as you brilliantly demonstrated in this case.
Thank you, sir. Thank you, sir. I think we should proceed to the next case.
Yes.
Next case is Stone Mountain, a walk in the park. And this will be presented by Dr. Aisha Kader. She is a very brilliant interventional cardiologist of the present time. And I appreciate her different types of works seen throughout the world, even in American Heart Association. May I invite Dr. Aisha Kader to present her case?
Thank you. Am I audible?
Yes.
Yes.
Thank you so much, Mora sir, for that very kind introduction, and thank you very much to BRIC for the opportunity to present our case. So unlike the live case transmission that you saw from our center about an hour ago, not every stone and every calcium is exactly a walk in the park. Some of it is more complex than others. And I'd like to present such a case. This was performed by Professor Said Rahman Khan, and I had the privilege of assisting him in this case. So this was a 59-year-old male who presented with chronic coronary syndrome and a positive exercise stress test. He was diabetic, hypertensive, and dyslipidemic with a normal ECG and a preserved ejection fraction. We approached through right radial access using a 5 French TIG catheter, and this is his coronary angiography. As you can see, the LAD, you can appreciate diffusely calcified LAD with significant disease in its proximal as well as mid part. The circumflex seems to be free of any significant disease. And the RCA is also free of significant disease. So this is before the injection of angiography, and the calcium is well appreciated on all views in a diffusely calcified LAD. So there are a lot of algorithms to tackle calcific coronary lesions, but there is beauty in simplicity. And this this recently published algorithm by Professor Javed Ahmed and colleagues from Newcastle in CCI is called AMASA, which is assess, modify, assess, stent, and assess, giving a significant sort of stress into intracoronary imaging in both the assessment as well as management of calcified lesions. So to just walk you through it, if when a de novo calcified lesion is found, the first thing to look after wiring is if it is balloon crossable, and if so, if it is balloon dilatable. And if not, the first thing to do is intracoronary imaging to assess for calcification. So in preparation to revascularize this patient, a JL 3.5 6 French guide was used to engage the left system, and it was wired with our workhorse wire, which is cyan blue. And pre-dilatation was done with an NC balloon, with 2.5 15 millimeter NC balloon at 16 atmosphere. As you can see, the balloon does not inflate entirely, and there's still an element of dog boning effect in the pre-dilatation, despite the fact that it's an NC balloon. And we know that angiography can visualize calcium in severe cases, but it's only the visualization. But in order to manage, we need intracoronary imaging, particularly to look at the depth of the calcium as well as the calcium mark, which is necessary in order to decide on the next strategy. So this is what was then proceeded to, and you can appreciate eccentric calcification here. Part. This is the distal part which is calcified, and then as it is approached more proximally, you can see a 360-degree napkin ring calcium in the LAD. So in order to tackle this degree of calcium, it wasn't going to happen with just a balloon. As you know, calcium can be eccentric when it's less than 270 degree, but in our case, which was this, it was 360-degree napkin ring calcium. So if we go back to the algorithm, when the angle or when the arc is more than 270 degrees, there are two options depending on the vessel size lumen as well as the depth of the calcium. It's either shock wave or some form of ablation, either rota, orbital atherectomy, or laser. But in our setup, we don't have a lot of tools, and the only ones we have are basic NC scoring cutting balloons as well as rotablation. So in this setting, the next step that we proceeded for was rotablation with a 1.5 millimeter burr at 160,000 revolutions per minute. You can see the pecking motion cracking the calcium in the early mid and proximal part of the LAD. And this is the picture after a couple of runs of rota. So after this, what do you do? Further lesion preparation is always advised with an NC at 1:1 high pressure, and then another assessment. So that's what we did as well. A 3 by 50 millimeter NC balloon was used. You can see here it takes time for the balloon to entirely fully dilate. And this was followed by the second assessment, which is after lesion preparation, IVUS run. You can see that there are parts where the calcium has cracked because of the effect of the rotablation. Like here, where there was a greater arc of calcium. And here. So after that, once the lesion has been fully dilatable, as evidenced by the fully dilated NC balloon, it is safe to stent now. And we then proceeded for stenting. The mid LED was stented with a 3.5 80 millimeter drug-eluting stent inflated to 12 atmospheres. And this was overlapped with a second 3.5 23 millimeter drug-eluting stent inflated at 10 atmospheres. After stenting, again, a third assessment according to the algorithm. So an IVUS catheter was taken down again because a fully well-expanded stent is of paramount importance, particularly when dealing with calcium lesions, in order to prevent bad outcomes downstream after stenting, even though it may look good angiographically. So this is the post-stenting IVUS. And more proximally, you can see there's a bit of malapposition, which needs a post-dilatation. Like here as well. So the lesions were post-dilated with a 4 by 8 millimeter NC balloon, inflated up to 14 atmosphere, both distally as well as proximally. And this yielded a satisfactory angiographic result. So this is the full algorithm. And learning points for me from this case are that lesions with high calcium content aren't always really a walk in the park. They require adequate lesion preparation for optimal stent deployment. Intracoronary imaging is imperative to guide an appropriate strategy as well as choosing tools. Each calcified lesion is different and should be treated accordingly. And it's important to use the appropriate tool for each lesion. For example, upfront versus secondary rotablation should be tailored according to the de novo calcified lesion. And AMASA, which is assess, modify, assess, stent, and assess, is a simple algorithm that appropriately guides strategy in calcified lesions. With that, I will thank you for your attention and thank you to my mentor, Professor Said Rahman Khan, for the opportunity to present this case. Thank you.
Thank you very much for the guideline-based management of this lesion. Professor Aman Kumar Chaudhary, sir, are you with us?
No, today he has not joined probably.
Dr. Pradeep Kumar Karmakar, Pradeep Da. Unmute yourself, please.
He is not with us.
Dr. Aisha Kadir, for your excellent deliberation. Every presentation which is presented by you is I enjoyed, and I think everybody enjoyed your presentation skill. And in this case, it is guideline based, and you did the good job. So everything is okay. I don't anything to say. Just is a good job. Thank you, Dr. Aisha Kadir.
Dr. Pradeep, are you in a library or virtual picture? Are you in a library or virtual picture?
Or it is a virtual background, sir.
Very nice. Thank you.
I have a query regarding AMASA. Last thing is assessment again.
Dr. Aisha Kadir.
Sorry.
Ashok.
Did you do the IBUS at the end of stenting and post-dilatation?
Not after the post-dilatation, sir. We did one pre-dilatation.
I request chairperson to comment on this because for any lesion that need IBUS, best thing, initially that IBUS is for assessment of the lesion, assessment of the measurement of diameter and calculation of length. But at the end, if you want to get a long-term good result, post-stenting and post-dilatation, IBUS is very much important, whether the stent apposition is good or not, especially such a long stent. What is your opinion? Chairperson, please, sir.
Dr. Professor Babunashvili.
I have a few comments. First of all, congratulations for the presentation and the excellent final results. And what I mentioned that radial and including the distal radial is acceptable for all kind of technological approach, including the rotablation. You used 1.5 millimeter of bar, what is the absolutely acceptable for distal radial, including distal radial 6 French guiding. But what I should say that we should always consider that OCT is more helpful and more valuable in detailed assessment of calcium and assessment of optimal stent deployment, because shows more accurately stent malposition than IVUS. But if we not have IVUS in cath lab, OCT in cath lab, we should use even IVUS for appropriate assessment final results. I totally agree with Dr. Ditta that we should assess final result, how we implant stent, how this stent is expanded, because malposition and full expansion of stent is most important for follow-up results. And you brilliantly demonstrate the role of intravascular imaging. And we should use always intravascular imaging for each step of calcium management, especially for the assessment of final result. Is the key message from me.
Thank you, sir.
Thank you very much. Thank you, sir.
Yeah, can I come into Dr. Ashok?
Yes, yes.
Yeah. Okay. Yeah, Dr. Ashok, because
Yes,
after
yes. Dr.
yeah,
Saidul,
I'm here.
that was a great case.
Yeah. The thing is that whether the hen is first or the egg is first, there is a question here. So after stanting, whenever you are, especially for a long stanting, when you have deployed the stents properly and angiographically you have felt that the stent is angiographically relatively opposed, but you know that even IVAS will tell really that whether it's truly opposed or not, or very small focal malpositions are there. So after stanting, if you do an IVAS, then you can understand really that whether there are some focal malpositions are there or not. Because if it's the gross malpositions, then angiographically you can understand that one and you can causality. But after stanting, to understand the real picture of malposition, then you have done the IVAS. So you have already done it. So when you have seen the IVAS, that some focal malpositions are there, and you have taken a proper balloon to oppose it, I think sometimes for time constraint or some other things, that
Yes,
again
sometimes we
another
also do
final
it.
IVAS this may not be needed because already you have taken an upsized balloon and you have ballooned it. Okay, so sometimes, because this is not all the time that is mandatory, but sometimes you may do it if you have that much
Dr. Ashok, your
time
net is
or
disturbing
to make it
probably.
that much.
Okay. But AMASA last word is A, so you missed the A.
Yeah, yeah.
Sometimes
That's
you
what
also
I've
miss
done
it.
after stenting. I have you tell after stenting you have done an IVAS, so that one has been done. Assess, stent, assess.
Yes. The
Very,
last assess
very.
is assessment after stenting.
Thank you very much.
I have some compliment to this case. Excellent presentation and doing the procedure, having the neck to the surgeon for calcium. Consultant for calcium, as because he has shown us just before live case the heavily calcified and here another calcified lesions, and so he has very
Dr.
fond of
This is for
calcium.
the juniors. This is for the juniors that how to end the procedure. That is for the juniors only. You did dilatation with 4O balloon, so I think this is sufficient enough. But anyhow, strategically to complete the AMASA, last assessment should be with the IVAS. Definitively, I like to congratulate you for such a difficult case to perform in such a great manner.
Thank you very much. The next presenter is Dr. Mahmood Hassan Khan. He will present on complex PCI, war in the midst of uncertainty. Dr. Mahmood Hassan Khan, please.
Sir, Assalamu alaikum. Am I audible?
Yes.
Thank you, sir. Thank you for your introduction. Assalamu alaikum and very good evening to the Honorable Chairperson, learned audience and panelists. Assalamu alaikum and very good evening. I am Dr. Mahmood Hassan Khan on behalf of Evercare Cardiology family presenting a case on complex PCI. As a fellow presenting the case on behalf of Professor Shahabuddin Talukdar sir, our patient, 55 years old, hypertensive, diabetic and dyslipidemic male, admitted as a case of unstable angina with a history of non-ST elevated ACS. ECG showed anterior ischemia and echo showed with regional wall motion abnormality, mild to moderate LV systolic dysfunction with ejection fraction around 45%. The CAG showed double vessel coronary artery disease with mild distal left main disease and recommended for PCI to left main to LAD. Before our recommendation, we did the syntax scoring, which showed a fair bit of high syntax, around 27, which according to the scoring system, the treatment modality was either CABG or PCI. According to 2018 ESC guideline for myocardial revascularization, the PCI is 1C and CABG is 1B. We explained to the patient and patient's family. The patient and family were not keen on undergoing CABG. They opted for PCI. So as we all know, the Medina classification, a true bifurcation involves both the both the main and side branch, that is 111. As we can see, our patient, according to Medina classification, has 110. So provisional stenting using a single stent or a two-stent approach. What should be the strategy? As we all know, according to the bifurcation lesion stenting algorithm, if the likelihood of side branch occlusion is low and the plaque burden is low in the side branch, so the provisional side single stenting is preferable. So we opted for a single stent approach for this lesion. Preferred choice of technique was provisional stent. So hardware used, right radial route was taken, an EBU 3.56 French guide catheter been taken, 2 floppy wires also taken. Pre-dilatation balloon was used with 215 millimeter and post-dilatation balloon was used as 410 millimeter and 3.5 38 millimeter. This was used to stent from left main to LED. So how it was done? Initially, both the left main to LED and SARC were wired. Pre-dilatation was done. After pre-dilatation, stent was positioned from left main to LED. Then the stent was inflated at 14 to 16 atmospheric pressure. Then post-dilatation was done with 410 millimeter balloon starting from 12 to 18 atmosphere pressure. After post-dilatation, it was ensured the stent apposition by IVUS run, which showed a fairly good, well apposed stent. And this is the final signal, which showed well revascularized left main to LED with TIMI3 distal flow. So according to different studies, comparing two stents technique versus provisional stenting technique in bifurcation coronary artery lesion, showed in developing countries with limited resources, the strategy of stent implantation in the main branch with provisional stenting of the side branch is the treatment of bifurcation lesion should be the preferred strategy. And randomized comparison of FFR guided and angiography guided provisional stenting of true coronary bifurcation lesion showed, based on the result, the current randomized trial, FFR guided and angiography guided provisional side branch stenting of the true coronary lesions are associated with similar MACE rates. So the take-home message from this case is single stent strategy appears to be less complicated. Try to keep the procedure simple. There is no hard and fast rule for the strategies. Every approach is overlapped with each other. IVUS guidance leads to lower MACE rates with decreased rates of stent thrombosis and target lesion revascularization. IVUS guidance is mandatory when treating complex left main and non-left main bifurcation lesion. There should be a plan B and try to keep your head cool. So thank you for your patience hearing.
Thank you very much. Thank you very much for your brilliant case.
Dr. Manohar,
yes.
If you give me the chance, I have some query.
Sure. Pradipda, please make some comments.
Yes.
No query, comments.
Yes. Thank you for your nice presentation. I want to say that there is no term is provisional single stand strategy. See, actually, provisional stand strategy is a philosophy. It may be ended up with a single stand. It may be ended up with single stand with kissing balloon.
Yes.
Even it may be ended up with the two stand. So you cannot say the provisional single stand. Number one. Second thing, during the post dilatation in your left main, the left main post dilatation balloon distal part should be at the carina, but your distal part in the LAD proximal part. Can you rewind your slide? It's for you learning things.
Pradeep, your comment is very much valuable and provisional. Can we tell it provisional side branch stenting? What is provisional side branch stenting? What do you think?
Actually, the provisional stenting means usually we should stent the main branch with a single stent. Then subsequently that can be converted into double stent in the
even or double stent in any end.
Now, for he's actually talking for the juniors. That provisional means that is single stent.
And regarding
single stand,
regarding post dilatation, whatever what Pradeep said, that is very correct. But this LM is very short. In this case, so far I have seen, I can memorize. It is very short. I do not think that is 8 millimeter is beyond the carina.
It is better to keep the balloon at the aorta, not in the LAD.
Crossing the carina.
Yeah.
I have one question to Dr. Babunath regarding such as provisional single stent strategy. Like here, he stented from left main to LAD across the LCX. Do you think that recrossing to the LCX and final kissing can give a better result? I'm not anyhow discussing the other case, his case. His case is fine anyhow.
As usual.
As usual, yes, sir.
Yes.
Okay. First of all, it's a very challenging case because we see very short left main. Yes. And always it's very difficult for managing, especially for stenting, because we should implant very carefully the stent, and more difficult is post-stenting dilatation. So I think that if we use the short non-compliant balloon 8 millimeter, if this balloon is going out of coronary artery and inflated into aorta, it contains the less risk if we inflate the balloon across the LAD ostium.
Yes.
So, and we should do NC balloon inflation port until the carina, not to extend it to side branch. I would say that thank you for this impressive presentation, because really this patient was challenging. We always schedule this patient for cabbage because of short left main and extended burden of atherosclerosis. But congratulations once again.
Thank you, sir. Thank you for a nice, encouraging comment. Thank you.
Thank you very much.
Thank you for your presentation. Nice presentation.
Thank you, sir.
Rest of the program will be moderated by Professor Sabina Hashem. Professor Sabina Hashem.
Is she with us?
She is with us. And
yes,
we have two more presenters, Dr. Smita Kanungo and Dr. Lipi Devnath.
for a long time she left us. That's because
Yes,
she was supposed to stay from the beginning.
I'm here, sir. I'm here from
Okay, thank you.
She is present from the beginning.
But she was silent.
But she remains keen.
May I ask Smita Kanu for presenting her case? Please, will you share? She is working in National Heart Foundation now. She always presents and very impressive junior cardiologist.
Thank you. Thank you, Madam, for your kind introduction. Honorable Chairperson, respected moderator, panel of experts and learned audience. Once again, a very good evening. I'm Smita Kanungo, working in National Heart Foundation Hospital and Research Institute. Welcome you again to my presentation, Tackling a Bifurcating Non-Lipid Lesion with Clot Technique. Before going to the presentation, I would like to take the opportunity to have some very few words about our hospital. National Heart Foundation Hospital and Research Institute is a non-government, non-profit organization developed under public-private partnership. It's a 480-bedded cardiac hospital fully equipped with modern tools and providing modern cardiac treatments at an affordable cost. At present, it has 5 full functioning cath labs. National Heart Foundation started its cath lab journey in the year 1999. Since then, till August 2020, more than 45,000 PCI were performed. And among the PCI technique, double-strand technique where consists the major portion. And we started double-strand strategies in 2015, but in the last 2 years, decay crush was increased in number.
Dr. Smita, your screen is not shared.
Okay.
Probably he's telling
your
without.
Screen share. Yes. You should share your screen.
Okay, sir.
Well, any slides?
Slide. Go to the share screen.
Screen
Is
share.
it?
No. It is
Okay.
Not yet.
Then I have to move out. I have
Smita madam, I'm requesting you.
Yes.
There is a option beside the chat option with the green screen, share screen.
Now I did click on that, but I don't. Should I?
Go out and once again enter.
Is it visible now?
Can we switch to the next speaker, sir?
You can give.
If it is a technical issue, she can fix it up.
And next.
Next speaker is Dr. Lipi Debnath. I'll finish that, then we'll come to again.
Okay, I'm moving out. Okay, I'm moving out. I will rejoin.
Yes.
Okay. So let's move to the next speaker, Dr. Lipi.
Smita will be the next.
Yes.
Lipi.
Lipi, could you please share your screen?
Yes, sir, am I audible?
Good.
Yes, you are.
Audible, visible.
And she's currently working in NICVD. She's an assistant professor there and very good interventional cardiologist as well. And I think, she is a very, she didn't want to present here. I just insisted her to do it. So she presentation from our center as well.
Yes.
Thank you, madam.
He is our cadet of National Institute of Cardiovascular Diseases.
Thank you, sir. Thank you for everyone for your encouraging, continuous encouragement. Honorable Chairperson, respected panelists, and August gathering. Very good evening. I am Dr. Lipi Debnath, working in NICVD. My case is all's well that ends well. My patient, Mr. X, 55 years of age, hypertensive smoker, presented with effort angina, ECG and echocardiography refers normal with good LV function, but ETT is positive in second stage. Coronary angiogram planned and it revealed. Left main normal, L6 is a codominant vessel with 90% stenosis in the proximal part. OM2 is large vessel with 95% proximal stenosis. LAD is type 3 vessel with 80% stenosis just before D1, and D2 is mildly diseased. And right-sided shot revealed RCA dominant vessel with 95% mid-level stenosis. So angiographic diagnosis is triple vessel disease with bifurcation lesion. The syntax score of this patient is 15, and our strategy is to do PCI. According to European Bifurcation Club consensus, the key principles of bifurcation PCI is to keep simple and safe, limit the number of stents, and respect the original bifurcation anatomy and try to reproduce it. And also should have an aim for well-approached and well-expanded stents with limited overlap. And among the different approaches, provisional stent approach is our main choiceable approach, and it focuses on main branch while maintaining the side branch patency. And regarding the side branch closure after PCI, different lesions regarding Medina classification, 111, that is lesion D, and F, that is 101 lesion. These have highest incidence of side branch closure during the procedure. As we all know, the simplest way to treat the bifurcation lesion is the provisional stent technique. And some recapitulating the fact is wiring both the vessels, pre-dilatation as required, stenting the main vessels, and then recrossing the side branch and balloon dilatation with or without kissing balloon inflation. This is the simple strategy. And it is simple because it has less metal load, easier to treat stenosis, but has some disadvantage because there is chance of residual stenosis at the side branch, and subsequent stent insertion may sometimes be difficult. And if a second stent is needed after provisional stenting, then there's several techniques can be adopted, like culotte, reverse crush technique, and tap technique. And few words regarding tap technique. As my case includes this technique, so I am going through it. Wiring of both the main branch and side branch, pre-dilatation as accordingly, then positioning and deployment of the main branch stent, then subsequent recrossing of the side branch and balloon dilatation, and positioning of the side branch stents by keeping 1 or 2 millimeter strut in the main branch, and deployment of the stent, and final balloon dilatation, kissing balloon dilatation. This is simple, definitely, and assures ostium coverage, less metal, and it is important when vessel sizes are of different sizes. But also some disadvantage because excessive stent protrusion can causes main branch access sometimes in future period. So my case, first wiring done, first LCX lesion was stented. First wiring done both in the LCX and left and OM2. Then pre-dilatation done in the accordingly. Then after pre-dilatation, the stent in the LCX is positioned and deployed. Then this is the after stent deployment of the main branch. Subsequently, recrossing done in the side branch. Further balloon dilatation of the side branch, and kissing balloon dilatation also with both the main branch and the side branch. This is after, and then side branch stent was deployed, positioned and deployed. Then after side branch stenting, IVAS run was done, and it showed that there is some malapposition of the stent at the level of the branch, and then subsequent simultaneous balloon inflation done. And this is after pot, the final IVAS run from pull back from distal to proximal. It showed well apposition of the stent. Then another technique that is adopted for our second vessel. This is modified gel balloon technique. This is safe and effective for preservation of the side branch patency during fraction stenting. And in short, for modified gel balloon technique, wiring done for both the main vessel and side branch. Then main stent is positioned in the main branch and balloon is positioned in the side branch. And both the stent and balloon are inflated at the same time in same pressure. And subsequently, wire and balloon is withdrawn and rewiring done, and final post-dilatation done in modified gel balloon technique. So this modified gel balloon technique is adopted for our LED lesions. First diagonal wiring and then LED wiring, LED is wired. Then IVAS done to assess the extension of lesion and also the severity of the lesion. And it has been shown that my at the level of the below the level of the diagonal, it has minimal luminal area 4.9 millimeter square and 63% plaque burden. But at the level of the diagonal, minimal luminal area is 3.1 and plaque burden is 80%. So our stent is proceeded to left LED, and balloon is positioned to the diagonal, and simultaneous inflation of both the stent and balloon done. The post deployment second IVAS was done to see the proper position of the stent with the vessel. Then there is some residual malapposition. So post dilatation was done, and this is the final picture. And this is the final IVAS shot. And all the picture shows there is significantly rise of minimal luminal area of around 9.2, 8.8, and 9.4 millimeter square.
Next.
And for RCA lesion, this is a simple lesion. So after wiring, pre-dilatation with the balloon done, and then stent is deployed directly, and TIMI3 flow is ensured. So in conclusion, bifurcation lesions are commonly encountered in clinical practice, and it is about 30% of the total PCIs. And in today's era, clinical outcomes of bifurcation PCI are very good, and multiple techniques have been developed to effectively treat the bifurcation lesions. Each has unique advantages and disadvantages. Being proficient with multiple techniques will assure us to perform PCI regardless of varying patient anatomy with excellent technical success. And a final message to remember that an interventional cardiologist must keep in mind regarding the KISS principle, that is, should keep it safe, keep it simple, and keep it swift. And I especially give thanks to our director sir, Professor Dr. Mir Jamaluddin sir, for doing such a nice case, and also Sabina madam for her continuous support and inspiration. And thank you all of the audience. Thank you very much.
Thank you, Lipi, for your nice case. And I think it's the same case you have done the double bifurcation, isn't it? The same case, one case or different?
Same
patient.
Same patient. So it's a very nice one that the patient had double bifurcation, and one you did the provisional tap, and the second one gel balloon. So and another thing I want to mention that the side branch was dissected. So it was very difficult, you know, if the wire doesn't cross in the lumen, true lumen, it would be difficult to stent, that one, and it was very nicely done. And the gel balloon, may I ask Professor Mir Jamaluddin sir to tell something about the gel balloon, because we for side branch protection we are frequently doing this gel balloon, and it gives a quite good protection of the side branch, and the procedure is as well as simple.
Thank you, Professor Sabina Hasham. Thank you. As you know, the gel balloon technique is a routine practice in our institute, and to avoid second stent. To avoid second stent, we mostly use gel balloon. And yesterday we have also shown another one case in live session that gel balloon technique has saved the side branch. And if the gel balloon does not give the good result, there is no TME3 flow, or there is dissection, in that cases we can require another stent, and that is approximately 10 to 20% cases. But 80% case, by using the gel balloon, we can avoid the further stent in the side branch. And that is the motto for using gel balloon, to protect the side branch as well as to reduce the number of stents. I want to know from Babun, what about you regarding the gel balloon?
We have not enough experience about the gel balloon, but in case like this, when we occurred dissection in side branch or main branch after predilation, we always use the two-stent technique, especially decay crush technique, because it guarantees to preserve the side branch, dissected side branch. And it's always easier and more safe than use another technique, for example, the gel balloon or gel wire, because dissected lumen is always quite difficult and quite risky to rewire. And most safe approach would be two-stent technique, especially decay crush technique.
Sir, I want to tell that for the side branch protection here, when the branch was dissected, I think they used a tap technique for that. And it was gel balloon was done in a LED and Devon, I think.
LED and Dangon.
Yeah. So that for dissected one, they used the tap technique. And with
but anyhow, Dr. Sabina,
yes.
In tap technique, you have to remove the side branch wire. So you have to rewire the side branch after putting the main branch stent. So we are losing the. So why Bhuvnesh sir is telling that decay crash is said to keep the side branch patent?
I have a question to Dr. Lippi regarding the gel balloon technique. What is the ideal balloon to vessel ratio? And another question is that up to what magnitude of disease you will allow while placing a balloon in the side branch without thinking of putting a stent at the very first impression?
Thank you, Professor Khaled Mohsen. Very interesting questions. First one, the dia of the side branch balloon will be not more than 50% of the main vessel stent. If we give 3 stent in the main vessel, then we will give 1.5 dia in the side branch usually. Second, the length of the balloon should be adequate to overcome the side branch stenosis. If there is side branch lesion within 5 millimeter, usually we do not require second stent. If it is even within 10 millimeter and we cover the entire length of the side branch disease with entering into the main branch, usually there is no dissection. Otherwise, there may be dissection and may require the second stent or only one stent we can use. Important thing is that to reduce number of stents. These are the metal, these are the metal, these are the thrombogenic, these are the restenotic notorious material. So if we can avoid second stent by these devices, you have seen or shown by the, it was shown by one Japanese, that Saito, the renowned interventionalist. He has shown 3 years ago that she has done 400 cases having no and from his speech we became interested, and in our country, in my institute, I and my team and different teams routinely use this.
Jamal bhai, what type of balloon you'd like to use? Use a compliant balloon or a semi-compliant or a non-compliant balloon in the side?
Usually it is semi-compliant, and it is also told how much pressure should be given. Pressure should be given. Usually it was told initially that 8 atmosphere, but in my practice, what I do, usually I do 12 atmosphere, side branch 12 atmosphere, main branch 12 atmosphere. And then after removing the side branch balloon, I have to do once again 12 atmosphere in the main vessel for close apposition, and subsequently if the post-dilatation is necessary with higher balloon, that we should.
Thank you, Dr. Lipi, for your nice presentation. But in LCX and OM, you have planned for TAP. You did the TAP?
Yes, sir.
Yes.
You balloon the both branches?
Initially, pre-dilatation,
initially.
both balloon.
Initially both?
Both.
But the grammar is, you should not predilate the side branch, because if the dissection happen, you have to stand the side branch first. So the grammar is, you have to predilate the main branch, stand the main branch, then rewire, then ballooning, and put then standing. And even after the kissing, it is always recommended, because after the kissing, the stent become ovoid shape. So a report is necessary. Have you got my point?
Yes, yes.
Yes, sir. Yes, sir.
No, he did the report. She did the report.
Report.
Next,
Report was done.
Manohar, next.
You did the report.
I can add one point here.
It should be before.
Yes, Professor Azam.
Yes, I can add one.
The case is nice, very nice case.
No, I shall have to know from my great Professor Azam. Azam.
Thank you very much.
What is your opinion?
My friend.
I know Professor Babun will already agree with me. ESC consensus, EBC consensus, 14 consensus was initial ethos of EBC to standard single stent strategy they actually adopt initially. And 2015, they also maintain it. First, their strategic approach, single stent strategy, if it is not suitable, if it is really better to protect side branch, then you should go for provisional or elective double stent strategy. Once you plan elective double stent strategy or provisional stent strategy, then you should consider regarding side branch whether you go for pre-dilatation or not. Otherwise, you don't touch side branch. If you want to protect your side branch, you just keep your wire down the wire in the side branch and down the main branch, then pre-dilate the main branch, then stand it, and then cord, and then you see, then the result is okay, then fine. If you think it is provisional stent strategy, then you may make a game plan from the very beginning of the procedure.
Is disturbing.
Yes, you make a game plan from the beginning of your procedure. If plan A failed, then you go for plan B. Thing is that in that particular situation, you should take some consideration other the bifurcation, vessel size, which technique you are actually experienced. Don't switch over from one technique to another technique. for the early career, interventional cardiologist should prefer for TAP technique, though it is recommended if angle is more wide, if more than 70 degree more, then you should adopt TAP technique. But if it is less than 70, if you are familiar with culotte, you should go for culotte, as because you know by definition culotte is the double provisional stent strategy. By definition, culotte is almost already explained. It is a provisional stent strategy. So you can go for culotte. If you initially think if side branch more than 90% lesion, critically lesion, if more than 10 to 11 millimeter, according to definition to trial, then you should go for elective double stent strategy in the form of DK crush is the better outcome in terms of short and long-term outcome, in terms of reduced target vessel MI, target vessel revascularization, in terms of instant restenosis. So actually every procedure have unique advantage. But in the comparison of the different study, according to DK Crush 3, DK Crush 5, and also definition to trial, definitely DK Crush is preferable. Once you decided, you go for elective double strategy, so you should go for from the very beginning. Otherwise, if you don't go for elective double strategy, not in the form of DK Crush, then you should keep in mind either you have to go for TAP or you have to go for culotte or to reverse cards or mini class, whatever you like, whatever you experience, that is the issue.
I have one question to Dr. Ajam.
Yes.
What is your choice of double strategy? Which DK crash, pull out, or tap? Which one do you favor most?
I personally prefer to do for DK crush if anatomy is suitable.
Okay, thank you.
If anatomy is suitable.
Thank you.
If anatomy is not suitable, then I should go for, if angle is more than 90 or 90 degree, then we should go for tap, or whether we should go for cooler.
Thank you.
Okay, I agree, Dr. Azam, with you, but most important point is what strategy, stenting strategy, we should intend it prior the PCI, because we have the minor and major criteria, what kind of stenting we should use in particular situation. If we have the huge plaque burden, if we have severe stenosis in the side branch ostium, or extended the plaque to side branch more than 1 centimeter, 10 millimeters,
10 millimeters.
we should use two-stent strategy, right? For me personally, DK crush is more preferable, but I am sure that interventionalists should use those techniques which is familiar with this technique.
Familiar with, yes.
If this is familiar for culotte technique, please do culotte. If you are familiar with DK crush is most preferable to stent strategy, because after DK crush, at least trials, they confirm that after DK crush, we have more preferable follow-up results comparing with another two-stent strategy.
Right. And as you know, the DK Crush 5 trial already showed DK Crush is superior to any provisional stent strategy, number one. Number two, definition 2 trial shows, yes, it is give more patency in side branch in terms of short and long 1 year outcome is good, very good. And again, and you see the DK Crush trial, another trial shows it is much more better than even than culotte. But you see, evidence you have, what evidence you have, substantial evidence you have, DK Crush is definitely very good in terms of better outcome. But I prefer for my early career interventional cardiologist, please, whatever procedure you are experienced, you are comfortable, you are confident, so that procedure. Then you can switch over after 50 or 100 cases, then you can switch over for your second strategy, like DK Crush, culotte, whatever you like to say. I agree with you. Demonstration.
Absolutely. Safety is the paramount importance.
Right.
Safety, first of all.
Safety and long-term outcome.
Yeah.
Thank you, Professor Azam, for your best compliment. Now I request Smita Kanungo to deliver her speech.
Yes,
Thank you,
now we
sir.
can speak.
Yeah, thank you, sir. And so really sorry for the technical delay. Honorable Chairperson, respected moderator, panel of experts, and learned audience. Once again, a very good evening. I'm Smita Kanungo, working in National Heart Foundation Hospital and Research Institute. Welcome you again to the presentation on tackling a bifurcating non-Lipman lesion with clot technique. Before going to my presentation, I would like to take the opportunity to have some very few words about our hospital. National Heart Foundation Hospital is a non-government, non-profit organization developed under public-private partnership. It's a 480-bedded cardiac hospital fully equipped with modern tools and providing modern cardiac treatments at an affordable cost. At present, it has 5 full functioning cath labs. National Heart Foundation started its cath lab journey in the year 1999, and since then till August 2020, more than 45,000 PCI were performed in our cath lab. And regarding the stenting technique, double stenting where consists the major portion. And regarding the strategy, we are using double stent strategy since 2015, but for the last 2 years, decay crush is increased in number. So with due permission of my consultant, I'm moving back to my presentation. Our patient, a 35-year diabetic hypertensive female, admitted in our hospital with non-STEMI. Her ECG shows T-wave inversion from in the anterior lead and echo-rival regional wall motion abnormality with mildly impaired LV ejection fraction. So with this view, we did the angiogram for the patient and which rival RC was free of significant diseases. But the left side rival disease, the LED was 99% stenosis. The diagonal also involved about 95 to 99%, which is also a good sized vessel. LCX was 30 to 45% stenosis at its origin. These are more view of LAD and diagonal. So now after having this angiogram, what could be the plan of treatment for this patient? Either we go for single stent, focused or double stent strategy. Before taking any decision, there are some issues that should be taken into consideration. Like the side branch, here is the diagonal is a large sized vessel, more than 2.5 millimeters, supplying a large area of myocardium. Both the LAT and diagonal are almost of equal size, and the angle between LAT and diagonal is less than 70. And while dealing with diagonal, there will be no proximal zone without covering the LAT. So all these features demand double stent strategy. And regarding the strategy, considering the vessel size and angle, we decided to go with for the culotte. So with this view, we took a 6-French guiding catheter and the LAD and diagonal was pre-dilated. Wearing was done with a floppy wear. Here we use the run-through wear. After that, pre-dilatation was done by 2O by 15 millimeter balloon. And this is the picture after pre-dilatation. At this point, we took a drug-eluting stent in LAD 2.75 by 28 millimeter drug-eluting stent, and the stent was deployed at 12 ATM. And then post-dilatation was done in the LAD by 3O by 12 millimeter non-compliance balloon. At this point, rewiring was done. First, recrossing the diagonal through the stent strut, and then this diagonal was rewiring. Usually it was done through the distal stent strut, and then the jail wear in the diagonal was removed and rewiring of LAD was carried out. This rewiring can also be done with a third wear, but here we did it with the help of the existing wear in LAD and diagonal. Then the stent strut was open and pre-dilatation was done at a 2O by 15 millimeter balloon. After that, another drug-eluting stent of 2.5 by 28 millimeter was placed from LAD to diagonal as we decided first for culotte. So, and the stent was deployed at nominal pressure. And this is the picture after stent deployment. At this pointed rewiring was again carried out, and this time with the help of a third wire through the double strand strut. First, the rewiring was pretty much challenging, but thankfully we were succeeded with the help of a microcatheter. And after the rewiring was completed, final kissing was done with 2.75 by 12 millimeter and 2.5 by 8 millimeter non-compliant balloon, keeping in LAD and diagonal respectively. And the final kissing was carried out with a simultaneous inflation and deflation about 14 to 16 atmosphere. This is the picture after proximal optimization, which was carried out by a 3/0 by 6 non-compliant balloon, and during pot it should be kept in mind that the balloon should be kept at the level of the carina. The distal marker should not be crossed with beyond the carina. And our vessels was carried out, which showed the vessels were fully open and well exposed apposition of the stent. And this is the final result, showing quite a good satisfactory 3-meter free flow in both the vessels. There are several studies between culotte and other double strand strategy. The Nordic study, which was carried out between crush versus culotte, which revealed that the clinical outcome was similar for patients with coronary bifurcation lesion treated with culotte or the crush stent technique. Another meta-analysis also revealed that target lesion revascularization and MIS were not significantly different between the crush and the culotte group. Another study between a double strand strategy between TAP and culotte also revealed that the chance of restenosis was pretty much higher in the TAP group. So we ended up with the conclusion that when the both branches are of equal size, culotte is the better option. Culotte probably gives the best coverage of the carina. Rewiring of both the branches to the stent strut is sometimes difficult and of course time consuming. While doing the double strand strategy, final kissing is mandatory. And obviously imaging gives a very useful tool while doing such procedure. As our mentor always said, that any successful of the procedure depends on the team effort. So from our hardworking and efficient team of Cath Lab NHF, I would like to thank you, and also thank you the BRIC Society to give me such an opportunity. It's a real privilege for me. Thank you.
Thank you, Smita, for your nice presentation. I know that Heart Foundation has done the highest cases at DK crash and culotte. So I have some questions that why you choose this one culotte, not DK crash, as the culotte has got less steps than the DK crash, but I think the culotte loses its main branch where DK crash you don't lose the main branch where. So why did you chooses the culotte?
Yes, Sabina, but I do totally agree with you. The DK crash should be the best, but as I already mentioned, as we consider the vessel size and angle, and as you already also mentioned a point that culotte with maneuver is a little bit less. So considering these factors, we did go with culotte.
And another question that and also this is for Ashok as well. So do you use catheters as a default approach for rewiring or recrossing the side branch?
Not actually, not always microcatheter, but sometimes when our wire become deformed, then microcatheter is better to avoid a new wire actually. And regarding the DK crash, DK crash, I think a bit tough because the angle between the LED and diagonal is less than 70. So anyhow, it is not good for tap also. And DK crash, maybe the procedure can be done, but it will be more difficult to recross the to the diagonal. So definitely tap both the what Dr. Ajom was telling. This is a double provisional stenting.
Yes. And where about the where? Which where you use for the side branch? Because you know when you do the
always floppy wire, either run through or Xion blue.
So
This is our,
we sometimes use the BMW because and the run through because both have some different in color. So it sometimes helps that to find out which way.
No, this is
yes.
very interesting.
There are some
Dr. Sabina.
techniques. Yeah.
When I went, when I went to the Euro PCR, that was long back, 20 years back. They used a small napkin-like
yeah, this is also a procedure.
So they put it on it. That is very much helpful. That is very much helpful. Otherwise, sometimes we do make an angle at the proximal end of the diagonal wire. Just a bend at the proximal end of the diagonal.
Yeah, sometimes it's difficult to find out which way to do. So, Professor, so our guest, Professor Babunaski, yes. Sir, will you please some comments for these
Okay, so about the once again about the two-stenting strategy, there's no significant difference as demonstrated in this presentation between type of two-stent strategy. It would be crash, reverse crash, or culotte, and so on. Only excluded decay crash, because regarding the decay crash, we have quite enough evidence that decay crash gives us more chance the good follow-up outcome comparing the another two-stent strategy. But once again, for me, from my point of view, safety is the first. If you are familiar with culotte technique, do culotte. If you are familiar decay crash, do decay crash. Because in follow-up, you might have the same clinical outcome. This is the first. Then another technical point is, I always, if I face the technical difficulties of rewiring the side branch, I always use pilot 50, pilot 100 wire to rewiring the side branch in case of difficulties. It's only a small technical point.
Yes. Sir, Professor Mir Jamaluddin, sir.
Thank you.
Comments?
We are almost near the end of the session, and before ending, this Smita has presented very nicely, interesting case, and this is their usual cases for National Heart Foundation. I am very much fond of their work. They are in the top list of cardiovascular disease treatment of interventional cardiology in Bangladesh, and we are the second position according to work. And I am Professor Mir Jamaluddin, Director, National Institute of Cardiovascular Diseases, and course director of this Bangladesh Radial Intervention course. And I am very much happy to meet with Babunaski in our session. And though you are in our session as guest from abroad as well as in a virtual fashion, but my wish that you will participate in the next year in Bangladesh Radial Intervention course conference. Bangladesh Radial Intervention course will arrange on 9th and 10th September 2021. You are invited to my program, and now I want to give the opportunity to all of the faculties, as because we are living just so very now we are living. So I like to know comments from my faculties, starting from Professor M.G. Azam regarding the break and today's 2 days conference and ending of this conference. Professor M.G. Azam.
Thank you, sir. First of all, I must give special thanks to our foreign delegates and our foreign faculties, especially.
I think Azam's net is not working, sir.
Can you hear me?
Yes, we are hearing, but we are thinking then you are an astronaut, whether you are in home or in
Thank you. I mean, on the way, sir. Anyway, I especially give special thanks to our foreign faculty who are joining with us. Really had a wonderful time, and we spent a lot of time with wonderful learning. And really, we discussed yesterday and today great cases involving with our young generation, our next generation, our ambassador, who will represent us. So, and as the same tone, I can say, Professor Mir Jamaluddin sir, we will be happy to have Dr. Bhuvan in our next program, upcoming program, 9th and 10th September 2021. Number one. Number two, our wonderful panelists and chairpersons already with us. I believe they will contribute with us their fruitful discussion that will help us, our wonderful audience, as well as our younger generation will be encouraged more. So I request our panelists and chairperson, please actively participate to our discussion for our next generation. Thank you very much, sir.
I like to hear a short comment from National Heart Foundation. The representative is now Associate Professor Dr. Ashok Dutt.
Thank you, sir. Thank you very much for arranging such a brilliant course. I think it will help the juniors, fellows, as well as all the seniors, because all the time there is no end of learning. From the seniors, yesterday we have learned a lot. Today we have learned a lot from our Babunash Bile. Already I have taken a snap with you. That is the virtual snap. So thank you, sir. Thank you on behalf of everybody from National Heart Foundation.
Thank you, Dr. Ashok Dutta. Professor Sabina Hashem, your short comment regarding our program.
So the BRIC was founded by Professor V. Jamaluddin sir, and Transradial is emerging in our Bangladesh, and we thought that we should do some programs or training the younger generations. So for that purpose, this BRIC was founded. And due to COVID, last year we had a very gorgeous and informative conference. This year, due to COVID, so we were thinking what to do. Then we thought that we should do some at least virtual one. So for due to virtual conference, the thing happened. The foreign faculties all over the world could connect with us, and special thanks to Professor Babunashvili so coming to our conference, and thank you very much, sir. And thanks to all the panelists who are attending and giving their valuable opinions in every perspective, and attending. And so it was a very informative and nice session. The two days we had 3 or 4 live cases, and it was all of them were very pretty good and very nicely done. 2 from our National Institute of Cardiovascular Diseases Hospital, and 1 from Heart Foundation, and and another from Ibrahim Care Hospital, and all difficult cases were done by radial approach and distal radial approach. So we are grateful to all of them for attending in our BRIC conference. Thank you all.
And thank you, Professor, Associate Professor Dr. Pradeep. Are you with us?
Yes, sir.
Yes. We want to have a comment from you.
Sir, I must appreciate the BRIC and the leader of the BRIC, Professor Mir Jamaluddin sir. You have did a wonderful job, because the radial intervention is started by your leadership in Bangladesh. And for the last 2 days, we have enjoyed a lot, we have learned a lot, because a good number of foreign faculties have joined, especially Tejish Patel and other foreign faculties joined. And this, though it is virtual, but we make it as live, because even in live situation, we have got more access and more learning points in the virtual. It is my experience. I have learned much more than the live one. Thank you very much, and we are expecting the brick will grade one grade up in the next year. We will come for your good health. Stay safe, sir. Thank you very much.
May I ask Khalid Mohsin sir to add something?
Mohsin is with us.
Thank you. Yeah, thank you, Professor Mir Jamaluddin, for your visionary and missionary role in popularizing the radial intervention in this country. Actually, your dedication and involvement is unparalleled. And I am seeing that you are sitting in your chamber of an ICBD, sacrificing your outpatient clinic and cath lab activity. And you are with us from the very beginning. And possibly after Tejas Patel, you have done the highest effort in popularizing the radial intervention in this country. The younger generation has adopted it as their route of choice, and the relatively experienced one like us, we are also getting inspired and switching over to the radial intervention gradually. So it is all credit goes to you, and hopefully Almighty gives you good health to carry on this effort. And the day is not far away that I think that at least 90% of all our cardiac interventions within next 2 to 3 years will be done by the radial route in this country, and we will bring down the access site related complication to a very bare minimum. So I hope your effort should be rewarded, and all the, I would like to thank all the faculties, participants from home and abroad for their active participation for making this program a success. Thank you so much.
Is there any other faculties of Bangladesh are with us at the moment?
Sir, may I say something, sir?
Yes,
Dr.
yes.
Anisullah.
Yes.
So that's a wonderful program. Today we enjoyed a lot and learned a lot under your leadership, as is all other faculty said, is become popularized. And I like to inform you that in Chittagong Medical College, we are doing more than 95% of our cases through transmedial route. And we are always, whenever we found difficulty, we contact with you and we get your always cordial response. We are very thankful to you. So may I have a small suggestion, those who participated this time for encouragement, is it possible to give them some certificate, something like that?
Yes. Yes.
Maybe
Yes.
that will be so helpful for them also.
Thank you for good proposal. It is in our mind, and we shall do it accordingly. Any other panelists with us at the moment? As because I am not seeing, that is why I am almost finishing. And before finishing the program, I like to tell Professor Babunas Bali for attending this session in with Bangladesh. How is your feeling, and what you will do for us, as because we have expected that you will come to Bangladesh, and for your kind information that distal radial approach in Bangladesh on 3rd December 2017 I have started, and in my case by this 2 year approximately more than 2000, and I have presented the result of 2000 cases of distal radial approach, both primary angioplasty and angiography, and all by the distal radial approach. Now my by default process is the technique is the distal radial approach. Whenever I fail distal radial approach, then I start radial, and I feel that distal radial is radial and radial is femoral. This is the feeling to me. So I like to have know from Babunas Billy regarding our program.
Thank you, first of all, for opportunity to chair this very interesting session. We discussed the overview, almost all type of coronary lesion and challenging cases. I am very impressed. And main conclusion from my side is that we should treat our patients safely based on current evidence base and current guidelines. And secondly, I'm very happy that radial access and distal radial access is so broadly accepted in Bangladesh. Thank you, and I'm ready to provide any support to help you and help Bangladesh interventionalists further success in distal radial access. Thank you for you inviting, and I'm ready to joining your society the next year when you decided the next event of Bangladesh Radial Society. Thank you again, and see you.
Thank you, sir.
Thank you, Dr. Babunas Bile. We are grateful to our father of cardiology of Bangladesh, who has started this program yesterday. He opened it yesterday, and our pioneer interventionalist, Professor Sufia Rahman. She continued the whole day yesterday, and we are also grateful to all of our senior teachers, senior colleagues, and as well as younger colleagues, and particularly of my institute, National Institute of Cardiovascular Diseases, all the young colleagues and my professors, associate professors, assistant professors, particularly they have attended the whole 2 days, yesterday and today. So I am very much grateful to them. Besides this, I am also grateful to all other institutes like National Heart Foundation, Ibrahim Cardiac Center, United Hospital, Apollo Hospital, Leavitt Cardiac Hospital, and cardiac hospital from outside Dhaka, from Chittagong. This is a remote place, but they are also doing very much good work in transradial approach. So I am grateful to all my younger colleagues as well as seniors for giving me giving us the time to develop this subject, and I am grateful to all of them, and particularly all the senior colleagues as well as younger colleagues, because all of them given us the opportunity to continue this program, and as well as foreign delegates, all the foreign delegates, particularly the mentor of me, that is in radial intervention, that is Dr. Tejas Patel, and the other all senior faculty from outside. We are grateful to all of them. And with these few words, I like to conclude our second Bangladesh radial intervention virtual 2020, and wishing all of you in next year's Bangladesh radial intervention course in 2021. Thank you all for kind attention and participation.
There should be a great clap for Mr. Jamal sir.
Thank you. See you.
Thank you. Assalamu alaikum, sir. Dhanyawad, sir.